See, you can read it from here.
Yes. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. Good afternoon, everyone. It's my great pleasure to welcome you all to our annual breast cancer meeting. And this meeting is sponsored by Faisal University, and CME Awards will be accredited from the university. I'm chairing this meeting annually with my co-chair, Dr. Mohammed Al-Garni. Dr. Mohammed Al-Garni is a senior medical oncologist, and he's the head section of cancer control and outreach program at National Guard Hospital, Riyadh. This meeting has been, as I mentioned, accredited by CME Awards from Faisal University. It will be over 2 days, today and tomorrow, inshallah. We're too delighted to bring together many attendees. We are having breast surgeon, we have surgeon, we have radiation oncologists, we have fellows, medical students, and nurses. And this is to emphasize the importance of having multidisciplinary approach for breast cancer management. On behalf of the scientific committee and organizing committee, I would like to sincerely thank you all for all the speaker, moderator, and attendees for accepting our invitation and being here today. I would like also to extend our thanks and appreciation to the scientific committee and organizing committee and the sponsoring company who used to generously sponsor our education activities. And these companies, namely Roche, Novartis, Lilly, Menarini, MSD, Pfizer, and AstraZeneca. Over the course of the day and tomorrow, we want to foster meaningful discussion, share knowledge, and explore the latest advances in breast cancer management field. We would like to encourage you all, the audience, to participate actively in the discussion, and would like also to encourage our attendees in the virtual setting to be part of the discussion, and they can feel free to send their questions and queries. Thank you all again for being here today, and I wish you all productive and inspiring meeting, inshallah. Thank you all. And this today we'll be having 2 sessions. In between, we'll be having a satellite symposium, and I'm very grateful to introduce our dear colleague and friends from National Guard Hospital and from Princess bin Sultan Hospital. The first session will be chaired by 3 eminent breast surgeon and radiation oncologist and radiology consultant, Dr. Maysoon Tahir, who's a senior radiology consultant at National Guard Hospital, Dr. Manal Zaid and Dr. Lurwa Reis, senior breast surgeon at National Guard Hospital, and of course, Dr. Abdulaziz Al-Hamid, well known to everyone. He was previously at National Guard Riyadh, but now he left us to Sultan Military Hospital. I would like to welcome you all, and let us start our first session, inshallah. Thank you all.
Hello? 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 Hello?
المايك.
الو. Assalamu alaikum. I would like to thank my Dr. Nafis and Dr. Garni for the invite, and my co-chairs, Dr. Manar Zaid, Dr. Al-Hamad, and Dr. Maysoon. I'd like to welcome Dr. Habibatullah Jamaluddin, who is a professor of surgical oncology and breast surgery in Cairo University. She's a leading surgeon in Egypt and at the regional level. Her contribution to auxiliary surgery is well known. Thank you, Dr. Habibatullah.
Thank you for the kind introduction, and I'm very pleased to be here today. I want also to thank the organizing committee for inviting me, and Dr. Nafisa Abdelhafiz for inviting me to be here today. So my topic is about axillary surgery, the evolving approaches in treatment of breast cancer. So I would like to discuss in this presentation few points about the concept of today's axillary management, the historical background, practice imaging, practice-changing trials, and how these trials affected or was translated into current practice, also the controversies and special situations, and the future direction in axillary management. So the concept of axillary management changed over time from a radical therapeutic approach to a more conservative staging approach that guides further treatment. And thanks to the multimodality therapy emergence and the landmark trials in axillary management, also the recognition of the prognostic significance of nodal status led to the change in the role of axillary treatment into staging only and guidance of decision-making. So let's take a look at the historical perspective of axillary management. So the concept of axillary dissection was introduced by Henri Legrand in 1757, and then Rudolf Virchow in 1866 led the foundation for understanding the role of axillary nodes in cancer metastasis treatment until the mid-1980s. And then come the Halsted era in the 1882 with the Halsted radical mastectomy, leading to routine axillary lymph node dissection in each patient and a very high morbidity and limited survival benefit. This changed into the modified radical mastectomy axiom of Patay and the new standard in breast cancer in the early 20th century. So the gradual de-escalation was due to a shift in practice paradigm starting in the mid-1980s, when surgeons began looking for less invasive and more targeted approaches to axillary dissection. Systemic treatment advancement and new drugs led to the recognition of overtreatment with axillary dissection and emphasis on quality of life and functional outcome. In the 1990s, there was an introduction of the sentinel lymph node biopsy as an alternative to axillary lymph node dissection. Because of many scientific advances in the 1960s, the sentinel lymph node was first introduced in parathyroid cancers by Gould et al. And then was used by Cabanas in penile cancer in 1977. And in 1992, the procedure was clinically applied by using vital blue dye and radioisotopes. Thanks to Armando Giuliano in 1994, who described sentinel lymph node biopsy as a safe procedure for staging the axilla for the first time. And then Umberto Veronesi confirmed the utility of the method by performing clinical trials. And this led to a pivotal scientific development for women with early stage breast cancer and a historical switch from axillary lymph node dissection to sentinel lymph node biopsy. So what about the sentinel lymph node concept? This is the first relay lymphatic tumor lymph node drainage, and 75 to 90% of the lymphatic drainage of the breast is to the ipsilateral axillary lymph nodes, and typically collecting in a single sentinel lymph node at the lateral border of the pectoralis major muscle. What about the landmark de-escalation trials? Two practice-changing clinical trials in the 1970s led to the practice that we are doing today. One of them, the King's Cambridge and the NSABP, the 4 trials that question the modified radical mastectomy axiom and randomized patients with clinically node-negative axilla to either early or delayed axillary treatment. Here are the key clinical trials shaping current axillary management, starting with the Z11 trial, Amaros, Z1071, the Sound trial, EORTC, NSABP 32, INSEMA, and Sentina trials. So the NSABP B32 trial was the largest of all trials on sentinel lymph node, and it was done to establish the efficacy and the safety of sentinel lymph node as a less invasive alternative to axillary lymph node dissection for staging the axilla. And it compared the sentinel lymph node biopsy followed by axillary dissection with sentinel lymph node biopsy followed by axillary dissection only if the sentinel lymph node was positive, and it had an impact on axillary management because this technique was adopted afterwards, not doing axillary lymph node dissection when we have a negative sentinel lymph node. So 2 randomized trials, the ACOSOG Z11 trial and the International Breast Cancer Study Group 23 trial, demonstrated that many patients with 1 or 2 metastatic sentinel lymph nodes can safely avoid a completion of axillary node dissection, and this means that we are going to omit the axillary lymph node dissection. The Z11 trial, led by Monica Morrow, omitting axillary lymph node dissection if 1 or 2 positive sentinel lymph nodes in breast-conserving surgery patients with clinically node-negative and with 2 positive sentinel lymph node. They were treated with breast-conserving surgery and systemic therapy. And this study found no difference in local recurrence or overall survival between the axillary lymph node dissection group and the sentinel lymph node biopsy in patients undergoing breast conservation surgery, with a 5-year overall survival of 92.5% versus 91.8%, and a 5-year disease-free survival of 83.9% versus 82.2%. The IBCSG 23 trial tested the axillary lymph node dissection. It should be avoided if metastases are detected in only 1 or 2 sentinel lymph node, and it was overemphasizing the results of the Z11 trial. And it was published in the Lancet Oncology in 2014, and they concluded that the Z11 trial and the IBCSG 23 trial will change the clinical practice, allowing no axillary lymph node dissection in many patients with early breast cancer, especially when the sentinel lymph node is minimally occupied by metastasis. So we reduce the axillary dissection need for early breast cancer. And then the shift was towards not doing axillary lymph node dissection and testing axillary lymph node dissection versus the radiotherapy. And this was done in the Amaros trial also in 2014, and it showed that axillary radiation is an acceptable alternative in patients who have positive sentinel lymph nodes but do not meet the D11 criteria. And the trial included more than 4,000 patients with T1 or T2 primary unifocal invasive breast cancer, meaning clinically N0. So if we look at the standard evolution from the advent of the neoadjuvant chemotherapy, we shifted from axillary lymph node dissection to sentinel lymph node biopsy plus subsequent possible axillary lymph node dissection. According to those trials that we see here on the screen, the Alliance Z1071 trial, the Sentina trials, and the SNFNEC trial, the Ghanea 2 study, Dutch population-based study, and the CLIP node prospective trial. The Z1071 trial, neoadjuvant chemotherapy and sentinel lymph node, was testing if we can do a sentinel lymph node biopsy after the patient receives neoadjuvant chemotherapy. And this concluded into that we can do the sentinel lymph node biopsy if the clinically N1 patients turn into a clinically N0. And then we can do the sentinel lymph node, and if it is negative, we can omit the axillary lymph node dissection, and the false negative rate was found to be 10% or less. Also, in patients undergoing breast-conserving surgery for invasive breast cancer, the treatment paradigm shifted from axillary lymph node dissection to sentinel lymph node biopsy plus subsequent possible axillary lymph node dissection. And then sentinel lymph node biopsy can be done with no axillary lymph node dissection in case of sentinel lymph node metastatic burden that is very low, and then axillary observation. Also, patients with DCIS used to have an axillary lymph node dissection for every patient until the 2000s start. Until today, when we do a mastectomy for DCIS patient, it is better to do a sentinel lymph node biopsy and then plus or minus axillary lymph node dissection, while in breast conserving surgery, we don't need to do it, except in case where we have a tumor that is more than 5 centimeters and of high risk. Now let's shift to another therapeutic option, which is observation, and this was proved in 2 trials, the SOUND trial and the INSEMA, and I will show you here the SOUND trial, which was first published in 2023 in St. Gallen, and they found out that we can do an observation of the axilla without any surgical intervention. It was done on more than 1,463 patients with tumors up to 2 centimeters and a negative preoperative high-resolution ultrasound. And they found no difference in disease-free survival or overall survival between observation arm and the surgery arm. Now we have the INSEMA trial, and this included 9% of mastectomy patients because the SOUND trial was only including those patients who will have breast conserving surgery. And it also proved that we can do the observation of the axilla. They tested in this trial patients with clinically node negative tumors and tumors less than 5 centimeters T1 or T2, and the omission of surgical axillary staging was non-inferior to the sentinel lymph node biopsy arm after a median follow-up of 5 years. The estimated 5-year invasive disease-free survival rate was 91.9% among patients in the surgery omission arm versus 91.7% among patients in the surgery group. So how these trials are translated into our current practice nowadays, we can see that the temporal de-escalation of the axillary management shifted from axillary lymph node dissection to sentinel lymph node biopsy with early clinically node negative breast cancer patient to omission of axillary surgery after negative sentinel lymph nodes, and then omission of axillary surgery after positive sentinel lymph node, and then omission of axillary surgery overall. And it also shed its light on the AJCC cancer staging system. As we see here, they assigned the term YP for post-therapy, and pathological anatomic category was based now on surgical specimen and sentinel lymph node biopsy. Also, there is a restaging of the recurrence. And for the prognostic category, the prognostic stage is determined by the tumor grade, biomarker status, and genomic panels. And also the pathological result of the sentinel lymph node biopsy number, which must not exceed 6 lymph nodes for sentinel lymph node biopsy, was designated SN. Now we have different current treatment modalities of the axilla. We have the surgery, the radiotherapy, systemic therapy, combination of the above, or even observation. We have indications for the sentinel lymph node biopsies, which are early stage invasive breast cancer with axillary lymph node negative clinically or radiologically, ductal carcinoma in situ, clinically N0 before neoadjuvant and clinically N0 after neoadjuvant therapy, and clinically N1 before converting to clinically N0 after neoadjuvant systemic therapy. The sentinel lymph node contraindications are still the same despite all the advancement, which are inflammatory breast cancer, invasive breast cancer with axillary lymph node metastasis, confirmed by needle biopsy after neoadjuvant therapy, and allergy to the tracer. Now I will give you a short note about how to do the sentinel lymph node biopsy. We should use a dual technique or a combination of methods. We have the blue dye, the radioactive iodine tracer, and the ICG, which can be done alone, the carbon particles, and the magnetic seed. And the sentinel lymph node is defined as one that localized blue dye and or concentrated radio-labeled colloid within a regional nodal basin. Now I will give you a short note also about the follow-up management for different sentinel lymph node status, and I divided it into two categories. When we do the sentinel lymph node without systemic therapy, previous systemic therapy, I mean initial surgery. So if we have a sentinel lymph node negative, no subsequent axillary lymph node dissection. If we have 1 or 2 positive sentinel lymph node in a T1, T2 breast conserving surgery, and whole breast radiotherapy will be planned, axillary lymph node dissection can be exempted. Also in total mastectomy, axillary radiotherapy plan, we can do axillary lymph node dissection can be exempted. And then if we have more than 3 positive lymph nodes, sentinel lymph node, we should do axillary lymph node dissection. Also, we can exchange the axillary lymph node dissection for radiotherapy when we have a clinically N0 disease and sentinel lymph node metastasis, positive sentinel lymph node, up to 3 positive sentinel lymph nodes. Patient without subsequent axillary lymph node dissection can undergo radiotherapy according to the Amaros and Ottawazor studies. But we have division radiotherapy should be determined according to the risk stratification. We have the lowest risk with no radiotherapy, intermediate risk exclusive level 1 and 2 radiotherapy, and the highest risk will have a full level up to 4 field radiotherapy, including the internal mammary nodes. What about sentinel lymph node after neoadjuvant systemic treatment? It downstaged the axilla, and it had an impact on axillary staging. It can convert clinically positive nodes to negative and may reduce the need for axillary lymph node dissection. Tumor biology and markers and tumor staging guide the choice. We have 2 methods for localization of the sentinel lymph nodes: post-neoadjuvant systemic therapy, the targeted axillary dissection, and the marking of the node, and also we have the sentinel lymph node. So we have some principles to undergo when we do axillary surgery post-neoadjuvant systemic therapy, because we have a high failure rate of 2.5% when the patient age is high, when the stage of the metastatic lesions of the axillary lymph nodes is high, and large size of the primary tumor, and also obesity. We have to mark the positive lymph node before neoadjuvant systemic therapy if the patient will undergo targeted axillary dissection. We have to assess the response to the therapy during and post-neoadjuvant systemic therapy, and the localization post-neoadjuvant systemic therapy for targeted axillary dissection should be done. And these are the procedures that we can do after post-neoadjuvant systemic therapy for oncological safety and low morbidity. This is the targeted axillary lymph node dissection. We can mark the node before the therapy, and then after the therapy, we do a sentinel lymph node biopsy together with excision of the marked lymph node. Before, they were saying that this lead to a low false negative rate, but then Montagna et al. Last year published an article that says that both are equivalent, sentinel lymph node alone or targeted axillary dissection alone, as a method for treatment of the axilla post-neoadjuvant systemic therapy. Axillary management in clinically N1 metastasis to movable ipsilateral level 1 or level 2 nodes. As I said before, we have the sentinel lymph node negative, no subsequent axillary lymph node dissection. Sentinel lymph node positive, we will do axillary lymph node dissection. And when axillary nodes are palpable from the start, it's better to do a neoadjuvant systemic therapy approach, especially in HER2 positive tumors and triple negative. And the further management option are either axillary lymph node dissection or sentinel lymph node biopsy if it turned out to be clinically N0 after systemic therapy. What about clinically N2? In clinically N2, even if it turns into clinically N0 after neoadjuvant systemic therapy, axillary lymph node dissection plus or minus radiotherapy is still the standard of care. What is the pathological significance of sentinel lymph node? After primary surgery, sentinel lymph node negative means a node that does not contain any metastasis or isolated tumor cells, but sentinel lymph node positive is one that contains macrometastasis, extranodal extension. Micrometastasis, when we do the primary surgery for the axilla with sentinel lymph node, it is also considered a negative sentinel lymph node. We don't need to do a frozen section, because according to the trials, this will not change what we are going to do in the surgery afterwards. But when we have a patient that undergoes sentinel lymph node biopsy post-neoadjuvant systemic therapy, it's different. Sentinel lymph node negative is defined as one that have no metastasis and or isolated tumor cells. Micrometastases were previously considered as a sentinel lymph node positive, but with new guidelines, it is now treated as a sentinel lymph node negative sometimes, and I will show you this in the following slides. For the sentinel lymph node positive post-neoadjuvant systemic therapy, these are nodes that contains micrometastasis or macrometastasis or extranodal extension. And here, the pathology should use the immunohistochemistry and the PCR for the evaluation of the sentinel lymph nodes. And the role of frozen section is important because it will change what we are going to do after the frozen section. Sometimes the sentinel lymph node biopsy is not the only lymph node in the axilla, but this is only for 0 to 11% of patients, and this is called the non-sentinel lymph node biopsy. And the rate increases to 20 to 35% in the presence of micrometastasis and after previous lumpectomy or recurrence. To summarize the type of axillary surgery according to the axillary staging, we have the upfront axillary surgery, clinically node 0, and we will do sentinel lymph node biopsy. Clinically N1 in early stage breast cancer, we are going to do systemic therapy or axillary lymph node dissection upfront. The neoadjuvant systemic therapy followed by axillary lymph node dissection is done in clinically N2 and clinically N3, whatever the response. And when we give the patient a primary systemic therapy, we have 4 categories. In clinically N0 response, they will do sentinel lymph node biopsy. Clinically N1 converting to clinically N0, they will undergo sentinel lymph node biopsy or targeted axillary dissection. As I said before, clinically N2 or N3 converting to clinically N0, they will undergo axillary lymph node dissection. Whatever the response, any residual disease in the axilla remaining, they will do axillary lymph node dissection. And this is the slide I was telling you about with the micrometastasis after neoadjuvant systemic therapy. The response will depend upon the type of the tumor. So if you have an ER positive, HER2 negative, triple negative, or HER2 positive tumors with ITCs, they will not undergo further therapy or nodal radiotherapy. But if we have 1 of 4 micrometastases, this will depend upon the biological type of the tumor. So for ER positive, HER2 negative, no further therapy or no the radiotherapy. And for the triple negative and the HER2 positive, which are considered high risk, they will undergo nodal radiotherapy or axillary dissection or both. If we have 2 or 4 micrometastases, all will have nodal radiotherapy or axillary dissection or both. 1 of 4 macrometastases, most of them will undergo nodal radiotherapy or axillary dissection in ER positive, HER2 negative tumors, but in the high risk tumors, still the treatment will be axillary lymph node dissection and nodal radiotherapy according to the risk. And this was published in the latest St. Gallen Guidelines 2025. So axillary lymph node dissection still has a role with the era of the neoadjuvant systemic therapy, yes, and it should be done when we have any tumor deposits in sentinel lymph node post primary systemic therapy. Lack of standard double tracer techniques in sentinel lymph node biopsy because we have a high false negative rate, and extranodal extension in inflammatory breast cancer or bulky nodal involvement in CN2 and 3 inflammatory breast cancer. There are ongoing trials for sentinel lymph node biopsy and de-escalation to try to limit the role of axillary lymph node dissection and the burden of the lymphedema that happens afterwards, and the shoulder dysfunction and the sensory deficits, and to have a better patient-reported outcome. Radiotherapy management also, it didn't undergo a lot of change, but as I said, we have the option now to either use radiotherapy or axillary lymph node dissection. And we have the standard whole breast irradiation that includes 2 tangential radiation fields to the breast or chest wall, and the full axillary radiotherapy is defined as the use of an additional 3rd radiation field, and even a 4th additional radiation field can be used to treat the supraclav and the upper axillary lymph node in some cases. and they are all treated, and axillary lymph node dissection can be omitted according to the Amaros and Otto-Wazur studies. What about the non-surgical axillary management? We have now the role of radiotherapy, as I said, and the observation of the axilla according to the sound and the INSEMA trial. And we have limited indications for the observation in T1 or T2 tumors in women with 70 years of age undergoing breast conserving surgery and tamoxifen therapy as adjuvant endocrine therapy. They can omit axillary surgery overall, even sentinel lymph node biopsy. This was the base of the sound trial and the INSEMA trial afterwards. So the current guidelines and recommendations for axillary management are emphasizing, and what I said, the ASCO, the NCCN, the ISMO, and St. Gallen guidelines. They have key recommendation, and this is a summary of all what I said. When we have a primary surgery indicated in clinically N0 or clinically N0 nodes, we can do a sentinel lymph node biopsy upfront. And if we have a sentinel lymph node negative, no further local regional treatment. If we have a sentinel lymph node positive, we have 3 options. If we have less than 3 positive nodes, we can do either omitting the surgery and go for radiotherapy according to the Amaros trial, or doing an axillary lymph node dissection. And if we have a sentinel lymph node positive, more than 2 positive lymph nodes or more than 3 positive lymph nodes, we can do axillary lymph node dissection. What about primary systemic treatment if indicated? If we have a clinically N0 but with a large tumor, or clinically N1, 2, or 3 nodes, we have to go for primary systemic therapy. And then according to the response, we have 2 options. Either it is a clinically node 0 after the primary systemic treatment, and then we should go for sentinel lymph node biopsy or targeted axillary dissection. And if it didn't change and still remains the clinically N1, N2, or NS3, we go for axillary lymph node dissection. And then the key take-home messages today is that axillary surgery has evolved toward de-escalation. And now we have many patients that can safely avoid axillary lymph node dissection. Multidisciplinary decision-making is essential, and ongoing research continues to refine patient selection during our treatment paradigm. And this is a picture from Riyadh, from the internet, of course, because this is my first time to visit your beautiful city, Riyadh, and I put it with one picture from Egypt. Thank you.
Assalamu alaikum. We will leave the question to the end, and Dr. Haba, great presentation, and we will proceed with the second lecture, please.
So the second topic today is about, it's not far from the axillary management because all involve neoadjuvant systemic therapy. Here in this presentation, I will talk about the impact of neoadjuvant systemic therapy on surgical decision in early stage breast cancer. I have no disclosures. In this topic, I will talk about why we use neoadjuvant systemic therapy for early breast cancer, and the effect of neoadjuvant systemic therapy on tumor size and stage, pathological complete response, the impact on breast surgery, the impact on axillary surgery, the current guidelines and evidence, the challenges and the limitations with the use of the neoadjuvant systemic therapy, and then the future directions and conclusions. So early breast cancer is not only one category, as we see here, in the AJCC staging system. It contains different categories from the ductal carcinoma in situ, lobular carcinoma in situ, and the T1 micro metastasis, T1A, B, C, T2, T3, even T3, early T3 is considered an early breast cancer. And also we have different biological subtypes, hormone receptor positive, HER2 positive, and triple negative, and this will all impact the treatment and the decision making. And we have here that the impact on the timing of surgery. So as a surgeon, I always said, why should I use neoadjuvant systemic therapy for early breast cancer? It's easy to remove it and then go. But the early systemic therapies initiated were tested in the adjuvant trials, and they were compared against observation or placebo. And also the early breast cancer treatment has evolved significantly over the past history and shift from a purely surgical approach to a multidisciplinary strategy, including local and systemic therapies, and also a shift from the traditional point of view of mine that we should start with surgery. Now we can start with neoadjuvant systemic therapy, and this for many goals that we have. The first goal and the most important one is the PCR, or the pathological complete response, which was proved by Cortazar et al. In 2014 when he did a pooled analysis of neoadjuvant trials on 12,000 patients. And he found out that achieving a pathological complete response strongly predicts improved outcomes and after neoadjuvant treatment, especially in triple negative breast cancer and HER2 positive tumors, with a less significant outcome on other types of tumors, such as hormone receptor positive HER2 negative tumors. So PCR became a validated surrogate marker for long-term survival, especially in aggressive subtypes. And here are some of the trials that was reinforcing the role of the PCR, like the Olympia trial, the CREATE-X, the Keynote 522, the I-SPY2 and the Keynote 756 and the Checkmate 7FL all investigated the role of the neoadjuvant systemic therapy in stage 2-3 triple negative breast cancer and HER2 positive breast cancer, and they found a high rate of PCR with a great statistical value. And here are some trials of sentinel lymph node post-neoadjuvant systemic therapies that converted clinically N1 to clinically N0. As I said in my previous presentation, we have the Acozub V1071, the Sentina, and the SNFNEC, and they all found a high PCR rate in the axilla if we use a neoadjuvant systemic therapy, with a false negative rate that do not exceed the 10%, which is acceptable. So the pathological complete response differs according to the biological type of the tumor. If we have a triple negative breast cancer, the PCR rate is up to 45%, which is a strong prognostic value. The PCR associated gives a favorable prognosis, and the residual disease is linked to a high risk of recurrence. In HER2 positive, the PCR rate is up to 60% with dual blockade, pertuzumab and trastuzumab used together, and they have an impact on the progression-free survival and the overall survival. For the luminal tumors, luminal A and luminal B, there is a lower PCR rate, but still it is present. It is from 10 to 24% and higher with Ki-high, Ki-67, meaning with luminal B types. The genomic assays may help identify who benefits from chemotherapy. What about the indications of neoadjuvant systemic therapy in early breast cancer and the role of the tumor biology? So who will use the neoadjuvant systemic therapy in which patient? The best candidates are those with node-positive disease, triple negative or HER2 positive tumors, high proliferative index, and particularly in R-negative ER tumors. Also, the guideline-based selection recommended by the NCCN is more for localized breast cancer. They make the decision based on the tumor size and molecular subtype, nodal involvement, and patient performance status and comorbidity. Age alone is not a contraindication to surgery, so let's not use age as a determinant which we are going to use. And a neoadjuvant systemic therapy may be inappropriate in some cases when we have extensive carcinoma in situ with fully defined invasive component. We should consider upfront surgical staging. The NCCN clinical practice guidelines recommend neoadjuvant therapy for inoperable breast cancer, operable breast cancer with HER2 positive or triple negative tumors, stage T more than 2 centimeters or N more than 1, large primary tumors in patients seeking breast conserving surgery and positive lymph nodes, and cases requiring additional time to plan surgery. And neoadjuvant systemic therapy is not recommended for patients with extensive intraductal components, unclear extent of invasive carcinoma, and non-palpable tumors or tumors that cannot be clinically evaluated. The drug selection will depend upon the biological type of the tumor based on the tumor subtype, the clinical status, or the tolerance of the patient. We have many choices now, not only chemotherapy, anthracycline plus taxane backbone, carboplatin in selected triple negative breast cancer. In HER2 positive tumors, we have the dual blockade, which gives the best PCR rate. And the ER positive tumors, endocrine therapy option versus the chemotherapy option in postmenopausal women is a standard care, but in premenopausal still under investigation. Now, if we give neoadjuvant systemic therapy for operable hormone receptor positive HER2 negative breast cancer patients, we have a PCR rate, as I told before, from 0 to 8 or 14% in luminal A and about 15% in luminal B tumors. Breast surgery conversion is up to 60% after neoadjuvant systemic therapy. So if the patient wants a breast conserving surgery, it's better to give her neoadjuvant systemic therapy. No pathological factor is consistently associated in this type of tumor with PCR and or long-term outcome. And as I said, neoadjuvant chemotherapy or systemic therapy should be only given in this category to patients requiring either axillary downstaging or breast conserving surgery. For HER2 positive breast cancer, neoadjuvant systemic therapy is a standard of care after T1. I mean, T1, you have the option of doing surgery versus neoadjuvant systemic therapy. But starting from T2, it's better to give neoadjuvant systemic therapy because of the PCR rate that is very high, with a dual blockade, trastuzumab and pertuzumab, to reach a PCR rate from 50 to 60%. There are certain drugs like lapatinib not supported in neoadjuvant setting, and anthracycline plus trastuzumab may increase cardiac risk, and this was in Berenice trial study with pertuzumab, they find no increased toxicity. Neoadjuvant systemic therapy for early triple negative breast cancer, which is a high risk biological type, should be started with, we should start with neoadjuvant systemic therapy, also starting from T2 and T3 and T4, but T1 still we have the choice between surgery and neoadjuvant systemic therapy according to what we have from the risk factors in each patient. And we have the KEYNOTE trial that introduced pembrolizumab for the neoadjuvant setting, and it increased complete remission by 13.5% and atezolizumab by 70%. Response improvement is independent of PD-L1 expression. Now I will get into the core of the topic, which is the surgical management of the neoadjuvant therapy. And it depends upon the type of the tumor and the downstaging that we need. So how did neoadjuvant systemic therapy impacted the surgical planning? We have principles that we have to do when we are going to give the patient neoadjuvant systemic therapy, starting with marking of the tumor, because we need to find it again after the therapy if we have a complete response. And then we have to localize it post-neoadjuvant systemic therapy, and of course the monitoring during and post-neoadjuvant systemic therapies that we are going to do with imaging like ultrasound or MRI to guide the surgical planning. And we have special situations where we have to stop the neoadjuvant systemic therapy if we have during the treatment a progressive disease or complete clinical or radiological response after finishing the treatment. How can we assess the response? We have the RECIST criteria, and these are the response categories radiologically. We have the complete response, the partial response, more than 30% decrease in target lesions, and the stable disease, neither CR or progressive disease. Progressive disease meaning we have 20% increase in the sum of the longest diameters of all target lesions. And of course, the pathological complete response, there is no standardization of its definition, but we have the most common definition that is applied, which means that we have an absence of invasive or in situ cancer in breast and lymph nodes. The prognostic for survival outcomes in the PCR is 7.4 to 30%, and it is subtype dependent. And of course, it is not used in inflammatory breast cancer. We have also a residual cancer burden index categories, the residual cancer burden from 0 to 3, starting from no residual to extensive residual. Of course, when we have a residual after systemic therapy, this means that we have a resistant disease that should be treated further. We monitor the response, as I said, with MRI, which is the most accurate for assessment of residual disease size and distribution pattern, but also what I prefer to do in practice is to use the same things that I used before the neoadjuvant systemic therapy, meaning that if you started with mammography, it's better to do it with mammography post-neoadjuvant systemic therapy. If you use MRI, use MRI. Also, ultrasound can also contribute valuable information. Ultrasound can contribute valuable information to the monitoring of the response. Now we have certain surgical considerations after neoadjuvant systemic therapy, the baseline and the post-treatment assessment. We have to know very well the initial tumor size, and it should not determine surgery type, because usually we do the surgery after neoadjuvant systemic therapy based on the new staging after the therapy. Here is a surgical approach for complete clinical and or radiological response post-neoadjuvant systemic therapy. As I said before, we should mark the tumor first before the therapy, and then after the therapy, if we have a complete radiological and clinical response, we should go for the clip that we put before the surgery, before the therapy, and put on it a wire. And there is many techniques used worldwide. Some people don't put a wire and use magnet, for example, to localize the clip. But the most important thing is after doing the surgery, we should do a radiograph of the specimen to make sure that we excised the proper or the clip and the tumor, the rest of the tumor. What about breast conserving surgery? This is our aim from all what I said, to reach the breast conserving surgery and to decrease the rate of mastectomy. So surgical selection post-neoadjuvant systemic therapy is dependent on the tumor response and the patient preference, and the guidelines recommendations is for tumor size less than 3 centimeters, appropriate tumor to breast volume ratio for good cosmesis, and we should achieve a negative surgical margin, no tumor on ink. Neoadjuvant systemic therapy can downstage larger tumors, enabling breast conserving surgery. The factors that are very important to consider are the pre-treatment tumor size and location, the molecular subtype, response to neoadjuvant systemic therapy, volume of residual disease, and patient age and preferences. We should not do breast conserving surgery after neoadjuvant systemic therapy if we have a large poorly differentiated carcinoma left, lobular carcinoma, large residual disease, volume, and non-concentric tumors shrinkage. We have different types of breast conserving surgery, starting from the very classic lumpectomy to level 1, level 2, level 3 oncoplastic and extreme oncoplastic. But in all this kind of breast conserving surgery, the most important thing is to reach a negative margin. And this is done by frozen section. In my practice, I use it always because when we do an oncoplastic technique after removing the tumor, we need to be sure that we have no left tumor, because we are changing the parenchyma distribution and we are bringing tissues from outside the breast to inside the breast. We have also now future trials trying to omit surgery after neoadjuvant systemic therapy. In exceptional responders, surgery may potentially be avoided if residual disease can be accurately excluded. Non-surgical approaches under investigations are to do an image-guided needle biopsy, advanced imaging techniques, but we have current limitations now, which are that the available diagnostic tools to detect the residual and to give me like a pathological complete response cannot be reliable until now because of the high false negative rate. So we have two trials, the responder trial using the vacuum-assisted biopsy with a false negative rate of 17.8%. This is not reliable across tumor subtypes. And the pooled analysis Royal Marsden and the MD Anderson trial, they used image-guided biopsy for residual lesions less than 2 centimeters. And they have a very high false negative rate of 18.6%. And also the MICRA trial with a false negative rate 47% after using an ultrasound-guided core biopsy. So these are all the trials that are ongoing now, and still there are other trials done to try to omit surgery overall after complete response. So what about the impact on axillary surgery? The neoadjuvant systemic therapy changed the whole paradigm in the axillary lymph node management, as I said in my first presentation. So we have an axillary downstaging after neoadjuvant systemic therapy up to 40% with anthracycline and taxane, and 50% in HER2 positive and anti-HER2 with anti-HER2 therapy dual blockade. We can use, as I said, sentinel lymph node biopsy, reduced need for axillary lymph node dissection, and there is a morbidity reduction with lymphedema and shoulder dysfunction. This is the Sentina trial that tested sentinel lymph node biopsy in patients with breast cancer after neoadjuvant chemotherapy and led to the adoption of sentinel lymph node biopsy when clinically N1 is converted to clinically N0. If we have a sentinel lymph node negative tumor or lymph nodes after neoadjuvant systemic therapy, no subsequent axillary lymph node dissection. If we have a sentinel lymph node positive, we need to do an axillary lymph node dissection. And of course, the use of dual detection methods and to retrieve 2 or 3 lymph nodes can achieve a very low false negative rate. And recently, ICG can achieve the same detection rate alone without the need of using dual technique. And this is the targeted axillary dissection that is equivalent to the sentinel lymph node, but with marking of the lymph node before the neoadjuvant systemic therapy, and then remove it after the neoadjuvant systemic therapy with the sentinel lymph node to decrease the false negative rate too. Still, axillary lymph node dissection has a role, as I said before, when we use a neoadjuvant systemic therapy in cases of clinically N2, N3 from the start, and N1 converting to N0, but with positive macrometastatic disease inside the nodes. Or patients with any degree of residual tumor cells detected in sentinel lymph nodes after neoadjuvant therapy should be considered sentinel lymph node positive, and of course, extranodal extension. So this is a summary of the axillary surgery approach post-neoadjuvant systemic therapy according to the response. Clinically N0, we will do sentinel lymph node biopsy. Clinically N1 converting to clinically N0. You can choose between sentinel lymph node biopsy or targeted axillary dissection. Clinically N2 and N3 converting to N0, we will still do axillary lymph node dissection. Any residual disease in the axilla, we will do axillary lymph node dissection. And this is the slide I've showed in my last presentation with the micrometastasis differing treatment according to the biological tumor. For triple negative and HER2 positive, it's better to undergo axillary lymph node dissection if they have 2 or 4 micrometastasis, but for ER positive HER2 negative tumor with ITCs, no further therapy or nodal irradiation, and with micrometastasis 2 up to 4, we don't need to do a nodal irradiation or axillary dissection or both. These are the current guidelines and evidence from the ASCO guidelines. We have to treat the patient with neoadjuvant systemic therapy according to the biological type of the tumor. In triple negative breast cancer, T1 tumors are exempted from a must use of neoadjuvant systemic therapy. So if we have a clinically node positive and at least T1C, it's better to do neoadjuvant systemic therapy. CT1A or CT1B and 0 can undergo systemic therapy or surgery from the start. For HER2 positive and for HER2 negative and hormone receptor positive tumors, as I said before, the use of the neoadjuvant systemic therapy is dependent upon the size of the tumor and the axilla. If the axilla is positive, it's better to start with the neoadjuvant systemic therapy unless it is a very small tumor that we can remove with surgery. And in postmenopausal patients, we can use a neoadjuvant endocrine therapy, and in premenopausal patients, it should not be used except in clinical trials. For the HER2 positive disease, we have the node positive or high risk node negative that should undergo neoadjuvant systemic therapy using chemotherapy and dual blockade. And pertuzumab may be used also with trastuzumab. In T1A, in T1A or B, N0 HER2 positive disease, the patient can undergo either surgery upfront or neoadjuvant systemic therapy. As I said, challenges and limitations are here because we have an imaging accuracy after neoadjuvant systemic therapy that is not met yet. Residual disease detection is important, and surgical margin assessment is very important. And also there is a risk of over-treatment or under-treatment. The neoadjuvant systemic therapy made us have the choice of the de-escalation of surgery and the de-escalation of the whole treatment of the breast and axilla. We have to look into personalized treatment strategies, biomarkers predicting response like the circulating tumor DNA. There are ongoing clinical trials to omit surgery overall after neoadjuvant systemic therapy after complete response, but it is still investigational. And the use of concomitant radical chemoradiotherapy is still investigated, but it is underway. Thank you.
Thank you very much, Dr. Hibatullah, for this rich, full presentation. And as Dr. Lulu mentioned, that we'll keep the question till the end of the session. Thank you very much.
Thank you.
For some unavoidable circumstances, we're going to skip the next lecture. We'll go to the next lecture after that. It's my pleasure to invite Dr. Amin Al-Umair, who's attending consultant King Faisal Specialized Hospital and Research Center, who did his training and fellowship in the University of Toronto, Canada. He's also a very close friend and colleague of mine. He's going to give us talk about radiotherapy in breast cancer patient who achieved complete response after neoadjuvant systemic therapy.
Thank you very much, Dr. Abdulaziz, and I would like to thank the organizing and scientific committee, particularly Dr. Nafisa and Dr. Germi, for the opportunity to be a presenter today. Also, for keep holding this very successful meeting every year. Personally, I enjoyed it very much. We learned a lot from this meeting. I also would like to thank you for the opportunity to talk to you today about the radiotherapy in breast cancer patient achieving complete response or pathological complete response after neoadjuvant systemic therapy. So let's go back historically and try to review the role of radiation therapy. Okay, it's working now. Let's go back historically more than 2 decades ago, where actually the role of radiotherapy is largely based on surgical staging. So every single patient will start with surgery, which either modified radical mastectomy for locally advanced breast cancer or lumpectomy for patients with early stage breast cancer. And since everyone is getting upfront surgery, we have pathological staging. And based on pathological staging, we can recommend the use or not to use adjuvant radiotherapy. So typically, locally advanced breast cancer is defined by advanced T stage, i.e. T3 or T4, or N2 disease, 4 or more positive axillary lymph node, or patient with 1 to 3 positive lymph node is a little bit controversial, but most of us will recommend adjuvant radiation therapy. This recommendation is being very consistent, and if you see international guideline, for instance, the NCCN guideline, it's also recommend the same. So let's move from locally advanced breast cancer to early stage breast cancer, where here patient had lumpectomy, and almost every patient who had less than mastectomy will get breast radiation plus minus regional nodal radiation. So if he had more than 4 positive lymph nodes, definitely will get regional nodal radiation. 1 to 3 lymph nodes is kind of controversial, with few exceptions. So maybe we can omit radiation for elderly patient, luminal A, and very small T stage. And the same recommendation is from multiple international guidelines. I'm quoting here the NCCN guideline, for instance, recommending the same. So this was typically recommendation in the 2 or 3 decades ago. Now there's a paradigm shift where most of cancer patients or breast cancer patients will receive neoadjuvant systemic treatment. For instance, this retrospective trial showing the practice change in the United States as the time goes by. So the neoadjuvant chemotherapy administration increased to double from 2003 till 2011. And if the guideline recommending neoadjuvant chemotherapy, there was slow adoption of this guideline as the time goes by. So initially, only 40% is recommending this before 2011. After 2011, you see this number start rising. I'll show it to you in a graph, stage by stage. So 3A, 3B, and 3C you can see there's consistent rise in the use of neoadjuvant chemotherapy. So we need to talk about radiation therapy in the neoadjuvant era. So what is the advantage of pre-op systemic treatment or neoadjuvant chemotherapy as opposed to upfront surgery? So we know that it's improved surgical outcome and convert inoperable tumor to operable tumor after chemotherapy based on the response. But most importantly, it's improved the likelihood of successful breast conservative surgery. So convert patient from mastectomy to breast conservative surgery. It also provides prognostic information. So those who achieve pathological complete response after neoadjuvant chemotherapy will fare better in terms of prognosis, i.e. survival. And this also, not only we should tell patients that your prognosis is better, but also this should be translated to guiding our radiation therapy. We should not use radiation therapy one size fits all from the beginning. So probably patients who achieved pathological complete response have better survival. We also want them to have less complication, less toxicity, less aggressive treatment. So let me walk you through the data for those patients. So, and the question that we would like to discuss is, in the PCR setting, do we recommend radiation treatment based on one size fits all, like pre-treatment regardless of the response to chemotherapy, or we should actually modify our treatment based on response to systemic treatment? And I guess the post-treatment assessment is very important, not only for prognosis, but also for guiding radiation treatment. So it makes a lot of, so this is the indication of radiation in the old era. If we want to modify it, it's wise to start with the most favorable group. So let's start with less T stage versus T3 and less burden of lymph nodes. So 1 to 3 positive axillary lymph node. And let's address the trial that try to omit radiation therapy. So we're not talking about patients who have large burden of nodal disease. So anything more than into disease or into disease is not the question of omission of radiation, even after PCR. We're talking about T1 to T3 and N10, as long as they have complete pathological response after neoadjuvant chemotherapy. So in those patients, the initial data was limited. It's retrospective, although it's a meta-analysis from multiple retrospective trials, but this was alarming. It's actually showed that if you omit radiation, there is no difference in survival, and no difference in overall survival or even progression-free survival. Definitely, if you add radiation, you're adding local control, but this was not translated into survival benefit, and it's not free of toxicity. But this is retrospective, even if it's meta-analysis. So Alembic all retrospective trial is still limited, and the most strong data that was published last year, well known to most of you or all of you, is the New England Journal publication last year, the well-known NSABP 51 trial and NRG trial. So this trial actually, what the question of this trial was the benefit of local regional radiation patient with biopsy-proven axillary node involvement at presentation that was converted to N0 after neoadjuvant chemotherapy. And the stratification was such that a patient should have T1 to T3 disease, as I mentioned. N1 was pathologically proven by either FNA or any way of tissue diagnosis that confirmed that this patient had axillary lymph node, whether by FNA or core biopsy. Those patients, every single patient in this trial received neoadjuvant chemotherapy. And after that, they randomized to regional nodal irradiation versus no regional nodal irradiation. So if the patient had breast conservative surgery, basically they randomized into breast radiotherapy alone plus minus regional nodal irradiation. And the primary endpoint of this trial was to evaluate whether chest wall irradiation in locally advanced breast cancer plus regional irradiation after mastectomy, or whole breast radiation plus regional nodal irradiation after lumpectomy improve the invasive breast cancer recurrent free survival. This was the primary endpoint. The secondary endpoint is listed here. It's basically local regional control, distant recurrence free interval, overall survival, progression free survival, as well as toxicity. And interestingly, I'll show you all the primary and secondary endpoint was a negative trial, which means that you can omit radiation safely. So for invasive breast cancer recurrence free interval, there's no statistically significant difference between the two arms. So did the other endpoint. Isolated local regional recurrence free interval is same. distant recurrence-free interval is same. You can see the curve overlap for disease-free survival, overall survival, and the conclusion is that in patient present with biopsy-proven node positive, limited node positive, 1 to 3 positive lymph node convert to N0 after neoadjuvant chemotherapy. There is no benefit of adding regional nodal radiation in any one of the listed endpoints. And this is the conclusion from the author itself. The addition of adjuvant regional nodal radiation did not decrease risk of invasive breast cancer recurrence or death from breast cancer in patients who had negative axillary lymph node after neoadjuvant chemotherapy. I've presented this trial last year in the same meeting, and the year before was only presented in a meeting, but now it's fully published in the New England Journal of Medicine. And now we can answer this question. So basically, for T1 to T3, N1 that was converted to N0 after chemotherapy, I will go with I can safely omit radiation therapy in both if the patient had breast conservative surgery or mastectomy. And let me go and refine this old guideline that was based on upfront surgery. So now T3, whether T3 N0 or N1 that converted to N0 is not an indication for chest wall radiation after mastectomy or regional nodal radiation. If the patient had T1, T2, and 1 to 3 positive lymph node, had mastectomy, I would not recommend regional nodal radiation. And a patient with breast conservative surgery, we're talking about early stage T1, T2, N1, which basically 1 to 3 positive lymph node, definitely I'll give breast radiation because patient had lumpectomy, but we can omit nodal radiation if the patient was converted to N0 based on chemotherapy. I guess the next question is, after breast conservative surgery, we always said every patient will get breast radiation. The question, shall we omit radiation in those patients? And I guess this was the ongoing, well-known de-escalating radiotherapy in breast cancer patients with pathological CR after neoadjuvant chemotherapy, well known as DSCAR study. It's an ongoing trial. And it's prospective, non-randomized, but it's multi-center single-arm study. Evaluate if radiation can be omitted in clinically T1, T2, N0 who achieved pathological complete response after neoadjuvant chemotherapy. The primary endpoint was the 5-year local recurrence rate. It will be published a few years ago. It still need probably 3-4 years before we can see the result. But it's very interesting. It might also change the practice. This was my last slide, and thank you very much for your attention.
Thank you very much, Dr. Amin, for this interesting talk. I think now we're going to start the questions. So,
First, I'd like to thank the informative update and details about the auxiliary surgical and auxiliary surgery. Now, my questions for evaluation for neoadjuvant chemotherapy. I think now it becomes as a standard care for patient to assess the number of them for neoadjuvant. My second question is regarding the recurrence breast cancer. What's the role of redo sentinel in clinical and radiologically negative in breast cancer surgery?
Okay, for the first question about the role of the MRI in the assessment of positive lymph nodes before systemic therapy. So MRI is not yet a routine investigation to be used in each patient. So we can use MRI or even PET-CT if we have a very high disease burden in the axilla. But the standard is to use mammography and the ultrasound to detect the axillary burden, specifically because we are talking about early breast cancer. So maybe we will have a clinically N1. But if we have a clinically N2 or clinically N3 disease, We can use MRI because it's the best practice, but it is not yet routinely used as a standard of care, and it is not written even in the guidelines as a first-line option. Specifically, that it is a very expensive, and maybe it is not present in many resources or in different resource settings. This is my answer for your first question. And then for your second question, I need further clarification. What I didn't get it. Please say it again.
Now, if you have a recurrent breast cancer.
Yeah. Okay.
And she came with clinical node negative.
Yes.
And about shall we do the symptom?
Okay, this was done in trials, but we don't have oncological data yet. But sentinel lymph node can be redone again when we have a negative axilla, but with a high failure rate. Specifically, if you have done before any axillary procedure because you disturb the lymphatics. So you have a high failure rate of doing the resentinel lymph node, but it can be done. Actually, it can be done. I have found many trials about it, and it is practiced. But you have also to see the recurrence is immediately after the first treatment or the period, the latent period between the recurrence and the treatment of the primary tumor. If it is a long time, it's usually the lymphatics reconstruct again, and you have not a native axilla, but it is better than doing a resentinel lymph node, for example, after 1 year or 2 years of doing a previous sentinel lymph node biopsy. And of course, after doing an axillary lymph node dissection, there is no role for resentinel lymph node biopsy.
But let me add one point. Sorry for.
Yes.
Now we have to consider in our practice the number of lymph node pre-surgery before treatment also. So if there is suspicious lymph node 4 or 4 or 5 or more lymph node, and she received chemotherapy, so we should consider in our practice the role of the axillary dissection in this case. Even if she had complete responding, it's very important that it be point for our practice.
Yes, it is very important, but we are relying upon the staging of the axilla according to the AGCC system, and it does not put into consideration the number of lymph nodes. It does put into consideration the difference. For example, for clinically N1, it's mobile lymph nodes. We don't look for the number as long as it is mobile. For the N2 and N3, we have different criteria like matted lymph nodes, like fixed lymph nodes, like contralateral axillary metastasis at the same time. So the staging system did not reflect yet the number of lymph nodes as a criterion for treatment of the axilla. All the care that we have now depends upon the staging that we are having in the AGCC staging system.
Hello. Just.
There's question, yes, sir.
Can I ask a question? So, Dr. Heba, first of all, Dr. Nafisa, thank you very much for a great Congress. Dr. Heba, thank you for an excellent presentation. And because as medical oncology community, and we are a bit skeptical about the de-escalation, especially in the Z11 trial, how about biology? What are the limitations for de-escalation beyond the trial guidelines or the inclusion criteria? So would biology, for example, differ in de-escalation if you have clinically node negative and then you do a sentinel lymph node, it's only 1 to 2 that are positive and you don't go for axillary dissection? Would tumor biology differ? Would the age of the patient differ? And so on. Thank you.
So the Z11 trial did investigate the different types of tumor biology, including HER2 positive tumors and triple negative tumors, and also hormone receptor positive and HER2 negative tumors. And the only on brand if it is possible for also patients with mastectomy, but this was further investigated with international study group of breast cancer, and they included patients with mastectomy who will receive radiotherapy afterwards. And for those patients who does not meet the Z11 criteria, we still can do sentinel lymph node biopsy if they turn from clinically N1 to N0. And this was proved by different trials. The tumor biology only differs in the response rate, but it does not differ whether I'm going to do sentinel lymph node biopsy or not, because the false negative rate of sentinel lymph node biopsy after neoadjuvant systemic therapy by many trials was proved to be less than 10%, which is okay. As long as I have a negative, false negative rate less than 10%, I can do the procedure for any type of biology. What else? The age of the patient, I don't think it differs because in my clinical practice, what I think is when the patient is very old, it's better to do a less invasive procedure and to do a sentinel lymph node biopsy. And we have the SOUND trial, which was based only on patients above 70 years or starting from 70 years old with observation of the axilla when they receive tamoxifen. We need to do less invasive procedure in older patients. It's better. In younger patients, we fear the recurrence and we fear everything, so we tend to be radical. And as surgeons, I prefer to do things that make the patient less worry, and but also within the practice guidelines that we are doing. Yeah, Z11 younger patients did not test the age because it's not a criterion, so it happened for all kind of patients.
Thank you for the speakers, Prof. Hiba and Dr. Amin. It was a really very nice, comprehensive talk. My question to Dr. Amin, every year you present this and we end up that we are not ready to change our practice. Now, almost after the publishing the B51, it is almost, I think, ready for to use. Now, my question, are you ready to use it first? And for all the patients, and regardless of the biology, maybe a similar question for Prof. Ola, question about triple negative luminal versus non-luminal. This is the first question for both of you regarding the caveats about the trusting the sentinel lymph node in our region. We know that there is some observational data that the practice of sentinel lymph node may be a little bit still not standardized in all the centers. So what is the most important point that you want to convey to our surgeons and pathologists regarding the false negativity and how to minimize in sentinel lymph node and any quality control, standard that will minimize such false negativity, and which is very important, especially with this de-escalation strategies. Thank you.
I'll take the first question and then order to allow me. Very good question. I was expecting this question because, to my surprise, and maybe Dr. Abdiaziz can also comment. To my surprise, I presented this 2 years ago or 3 years ago based on abstract, and the adoption of this trial has been. Most of half of radiation oncology are skeptical, which is surprising me. In our center, and this is why I want also the experience of Dr. Abdiaziz, one of the senior radiation oncologists. In my center, we have one senior radiation oncologist who used to run all the cases. She adopted this from the beginning, and in our center, if the patient is fitting the criteria for NSABP 51 NRG, we just do it. In fact, the biology of the trial, although the number is small, giving you the other way around. You expect that, you want her to triple negative to be aggressive with them. In fact, the other way around, in the trial, but this is subset and small number of patients, so no one will even. So you can't even say, I will see the biology and aggressive biology, I'll go aggressive and give radiation. You need to omit radiation for every single patient. This is my bias. And initially, radiation oncologists said, well, this is abstract. We will not change our practice. And I don't disagree in the first year, but now it's published June 2025. So it's been now a year. The study was published. They're saying, their argument, the one who does not adopt this trial is, you need longer follow-up. but most of the patient, you're not expecting late recurrence. So you have a HER2 enrich, you have luminal A, you still can apply this for them. Waiting long does not give you anything. But I'm surprised that people are very skeptical and very slow to adopt the trial. Go ahead, Dr. Lisa. Do you want to ask?
Maybe difficult to adopt, Dr. Amin, because you remember you used to give radiation even for tumor less than 5 centimeter, negative lymph node because of the bio.
It's true.
Yes, this is triple negative. We have to give. She's young. We have to give. This is HER2 positive. A negative lymph node, but you rush for. You used to give radiation.
Correct.
Now we are upgrading this, saying that even patient with positive lymph node tend to be negative after neoadjuvant. So it's very hard for us to swallow as medical oncologists. And I think we needed time, but it's up to you guys. But you have to we have to convince us.
Sure, yeah.
With the new data.
I agree. This is I'm not criticizing. I'm saying it's really slow adoption. In our center now there's more than one radiation course, 3 or 4 radiation courses treating breast cancer. You can see the practice is varied. Also, when I go to Eastern Province, Western Province, I find it 50-50. You're right. It seems that there is something not scientific, sometimes very difficult for someone who believes that the more the better to adopt a trial. And I think now it's published in a full manuscript. It's very convincing to me, at least. Abdulaziz, what's your practice in the military? Because I kind of know the practice at a different center.
Okay. There is few points. The first one, a lot of trials, when you try to translate it to the real life scenario, doesn't go with you as a trials, because the time frame in the trials very strict, from investigation, diagnosis, chemotherapy, and surgery, then to decide decision for radiation. And here, that the intervals is expanding. You see sometimes patients being diagnosed at chemotherapy or surgery, it takes 2 to 3 months for an exceptional reason. So that's give us also make us hesitant to follow these trials, because these trials, if you go details, as they said, the devil in the details. They have very strict timelines between the diagnosis, starting with the treatment, which cannot translate it in our public system.
Sure.
The second point, our standing now for radiation, we have to stood up for our specialties. Radiation is very safe medication compared to our colleague medical oncology. They raise a lot of campaign about cardiac toxicity, but I can give you 100 grade radiation is less toxic than 2 cycles of AC for the cardiac. So this is very safe medication treatment. I don't know why there is rush to avoid.
So
the third point is nowadays, a lot of radiation oncologists, the junior, they start to do the contouring, not like what we used to do tangential. So it's in very limited field of radiation. And the last point is the patient fairness. We are still in the third world countries. A lot of the patients, they don't have quick or simple access.
Take radiation or
I give the two
or
options.
you tell them that the trial now is published?
No, I give the two options, the pros and cons. My comment.
How about your colleague in military? Like, do they have split practice or they do it like you?
I think I'm the only one doing breast right now. So.
Which is bad, eh? There's other question. The question was too hard. Yeah. We need to know also in Egypt, how do you guys adopt the trial?
this what I want to say is that in Egypt, in tertiary care center, for example, at the National Cancer Institute where I work, I'm undergoing now a research about the validation of all the trials done on sentinel lymph node biopsy, meaning upfront surgeries with sentinel lymph node biopsy or primary systemic therapy followed by sentinel or surgery, yes. And I still don't have the result, but I can tell you from my practice that it took us maybe 2 or 3 years to realize that it is an option and that we can do it. We have all the facilities to be done, specifically that we are a tertiary care center and we have all we have a comprehensive care for the patients. But when I work outside the National Cancer Institute, where the facilities are not all available, surgeons specifically are very skeptical about omitting axillary lymph node dissection. And my younger colleagues used to ask me if they have a one sentinel lymph node positive, would I omit the axillary lymph node surgery? And I tell him, yes, omit it. And they are very, very skeptical. And also the second point is the resources that we have in our region is different from what happened in the trial. I mean, the trial is always in an ideal setting. They do it in ideal settings with everything available with certain criteria. But when we put it in the real life, it's not the same. That's why, for example, post-neoadjuvant systemic therapy, they tell you that you should use, for example, a dual tracer. And one of the questions I asked Monica Moro in St. Gallen 2 years ago was, what if I don't have the dual tracer? Should I continue doing the sentinel lymph node biopsy or should I go directly for axillary lymph node dissection? And her answer was really shocking to me because she told me, yes, give the patient the chance of sentinel lymph node biopsy. And if you don't find the sentinel lymph node, okay, go for axillary lymph node dissection. Because when I read after this, I find out that the recurrence rate after sentinel lymph node biopsy is not more than 2%. So it's not a very big deal, to have just give the patient the option of doing less invasive surgeries because of the side effects that we see after the axillary lymph node dissection. We have a very high number of lymphedema necessitating many conservative and surgeries to overcome. Also, we have now for the axillary lymph node dissection many challenges in the vision. For example, if you are not sure whether the number of lymph nodes positive will dictate further treatment or not, I think this was investigated in the trials, and we should go now for adopting these trials, but in our setting, and we should publish this. I think the literature needs our impact from the vision about how we deal with these trials coming from outside, how we see the results, how we are doing in our practice. We need to publish this, and to each one of us working in a center, publish what we are doing and seeing if we can, if we have the same result as the USA and Europe.
Interesting. Thank you.
I would like to thank Dr. Nafisa for her kind invitation and for the speaker, Dr. Amin, Dr. Hiba. We really enjoyed your presentation. It was very interesting, informative. My question to Dr. Amin regarding scenario for early 40s female, her clinical staging T4 N2, M0, triple positive. She received total neoadjuvant systemic therapy and then underwent total modified radical mastectomy plus axillary clearance.
And
Her pathology, excellent response. Her pathology, TIS N0. My question, in this situation, would you recommend post-mastectomy radiation therapy to chest wall and Nagdella or not, regarding her age and her clinical stage?
As well. I would recommend chest wall. I'll ask Dr. as well. This is T4N2.
Yes.
If you see my slide, we try to skip radiation now in T1 to T3 N1. This patient will tell her your prognosis is good, but sorry, when she needs comprehensive radiation to chest wall, axilla, supraclav, and maybe some people will even give the IMC, which is not common practice, just to maximize her chance of local control, even after breast conservative surgery. So usually the trials start with T1, T3, N1, you know what I mean? And then, which is now positive, we can omit radiation, in my opinion. Then they will move to T1, T2, which is ongoing trial after complete response. You might not give, even after lumpectomy, you not give breast conservative surgery. This is the next step. Then they might come to T4 N2. You know what I mean? So
Actually, my question, do we based here on the clinical stage, the pre, or on the response?
True.
Is this risk or response based?
for T4 or N2, now we're giving me combination. If one of them is present, if it's T4, I will give radiation. If it's T4 N2, I'll give radiation to chest wall and nodal. If it's N2 only, without T4, I'll give radiation to chest wall and nodal and supraclavicular.
And if there is extracapsular extension.
Yeah. Okay, go ahead, please.
And if there is extracapsular extension, for sure.
Say that again.
If there is extracapsular extension.
يعني ما فهمت.
Extra nodal extension, even for N1, we give radiation.
Sure. But for this scenario, I think everyone will give radiation. T4, N2 achieved complete response. It's not a question of evidence. She will get radiation anyway, right?
Yes.
Yeah.
Thank you so much. Thank you for the speaker for the nice presentation. Maybe this should be the last question. Another one. After this good discussion, I listened to most of the speaker was medical oncologist. So I am medical oncologist. I want to show my input regarding this this difficult discussion. For now, I think we are less confident to omit the axillary lymph node or radiation in a patient who received neoadjuvant chemotherapy, and we converted the lymph node from N positive to N0. We are still less confident. You present a good data, maybe supporting in the future we can apply it, but it's still, I think we have to consider that the axillary lymph node or radiation based on classic situation from there. But recently we have precise medicine. We have some guidance that we can add adjuvant abemaciclib, palbociclib, olaparib, other things. Does this may substitute or make us less enthusiastic to use axillary lymph node or radiation in such situation or not? I think this is a question now.
What's the question, sorry?
It is just it is a matter of comment that we are less confident to omit axillary lymph node or radiation in such situations that when we use neoadjuvant chemotherapy, converting lymph node positive to negative pathologic complete response. We are not considering the new data that we can use another treatment targeted therapy in this situation, because still we are dealing with surgery and radiation as a classic approach in our patient. Maybe in the future this may be changed.
And I agree with you. And I think not we are less confident, but also the adoption of this trial has been very slow. And this is why the organizing committee and the scientific committee each year repeat the same trial. And each year I show you one trial, the adoption of new adjuvant chemotherapy in USA, in an academic center was 40%. When every single guideline is including new adjuvant chemotherapy for those patient category, then after a few years it go to 60% and continue to rise. So I think the adoption here will be, hopefully, inshallah, next year will be better.
Okay, thank you very much. Thank you for very fruitful discussion and informative presentations. We can break now and move to the next session in a while.
We are in a break for 10 minutes and then we'll be back. Break for 10 minutes, then we'll be back.
Assalamu alaikum wa rahmatullah. I'm ready to start whenever it's time to start.
Walaikum assalam. 1 minute, Dr.
Sure.
Assalamu alaikum. This is our first satellite symposium for today. It is by Lily, and I'm glad to introduce my friend and colleague, Dr. Ahmed Al-Shihri. Dr. Ahmed is a senior medical oncologist at National Guard Jeddah, and he will talk about evolution of CDK4/6 inhibitor in the management of hormonal positive HER2 negative breast cancer. Dr. Ahmed, nice seeing you virtually, And hopefully very soon we'll see you physically in Riyadh. Dr. Ahmed, please, the floor is yours.
Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh. Jum'ah Mubarakah ala al-Jami'. Thank you, Dr. Nafisa, for the kind introduction. Thank you to the organizing committee, Dr. Nafisa, Dr. Muhammad Al-Garni, and I'm really sorry, apologizing for not being physically with you for some social reasons arising over this weekend. And thank you, Lily, for inviting me to talk about the anti-CDK4/6 in the management of hormone receptor positive breast cancer. These are my disclaimer and disclosure. Okay, start with abemaciclib, as you know, is an anti-CDK4/6 that have been approved for both indications in early breast cancer, high risk early luminal breast cancer, and in metastatic luminal breast cancer, whether in the first line as endocrine therapy sensitive patients or in the second line as endocrine therapy refractory patients. And we'll go over the details of these clinical data. And so let's start with the high-risk early breast cancer. When we talk about high-risk early breast cancer, I refer to node-positive breast cancer. If you have a patient with a node-positive risk breast cancer and high-risk features like tumor size of 5 centimeters and above or grade 3, usually they have higher than usual risk of recurrence. And this kind of risk of recurrence usually peaks in the first 2 years. So it's very important to maximize preventive measures in the first 2 years to reduce the risk of cancer recurrence in these high-risk patients. Real-world data, it was found that almost 70% of patients are undertreated, despite the fact that they have high-risk features, suggestive of a higher risk of recurrence. And only 30% they receive proper anti-CDK4/6 management in addition to their endocrine therapy. The reason for that may be due to lack of knowledge of some of the medical oncologists about the bad outcome of these high-risk hormone receptor positive patients, or sometimes patients are not convinced enough to receive these treatments because they don't understand the outcome of these high-risk features. And finally, it could be due to availability of anti-CDK4/6 in clinical practice. If you look into this table, which is a very interesting table, that compares those patients with N1 disease, meaning 1 to 3 lymph nodes. Those who don't have high-risk features like large tumor size or grade 3 cancer, usually they have a lower risk of cancer recurrence. However, if we compare those patients with N1 disease, meaning 1 to 3 lymph nodes, and with additional high-risk features like larger tumor size or grade 3, usually they have a relatively high risk of recurrence. You can see in the range of 26%, meaning 1 out of 4 patients might have cancer recurrence over the next 5 years, which is very close to those patients who have N2 disease. If you see those patients who have 4 and above lymph nodes, the risk of recurrence is ranging between 34 to 35%, meaning 1 out of 3 patients will have cancer recurrence in 5 years. The question, how can we reduce the risk of recurrence in these high-risk patients? Look at this patient, a 45-year-old lady, perimenopausal, hormone receptor positive, HER2 negative disease, diagnosed with stage 2B luminal breast cancer. She had a tumor size of 5 centimeters and 1 lymph node positive. So if you see here, she has N1 disease because of presence of 1 lymph node and 1 additional risk factor, which is the tumor size of 5 centimeters. This will put her at risk of cancer recurrence, as we mentioned before, in the range of 26% in the next 5 years. So how can we reduce the risk of recurrence? This is where Monarchy trial came to answer this question. So they included those patients with hormone receptor positive disease, early breast cancer, of course, if they have node positive, N2 disease, or N1 and tumor size of 5 centimeter, or N1 and grade 3. Those patients have been randomized after, of course, the standard treatment of chemotherapy and radiation to receive their standard endocrine therapy approach plus minus abemaciclib. So abemaciclib is the investigational intervention in this study. The primary endpoint was the invasive disease-free survival. The dose, the standard dose of abemaciclib was 150 milligram twice daily in a continuous dosing or schedule up to 2 years from starting the adjuvant endocrine therapy. So what about the long-term data? We have the longest data ever to date when it comes to adjuvant anti-CDK4/6 management. So we have the 7-year data. You can see this is the primary endpoint, which is invasive disease-free survival. So at 7 years, the risk of cancer recurrence or death was 70% for those who did receive endocrine therapy and abemaciclib versus 77% for those who received endocrine therapy alone. So this translates into absolute difference of 7% protection by abemaciclib, meaning out of 100 patients treated with endocrine therapy and abemaciclib, we prevented cancer recurrence or death in 7 patients. And this, in relative terms, translates into 27.4% reduction in the risk of disease recurrence or death, which is meaningful clinically and statistically was significant. Furthermore, in the most updated data at 7 years, we finally got what we need with regard to overall survival benefit. You can see at 7 years, there was a risk reduction of cancer, breast cancer death by almost 16.5% by addition of abemaciclib to the baseline or background of endocrine therapy management. Another secondary endpoint is the distant relapse-free survival, which is an important and significant endpoint indicating the reduction in the risk of distant metastasis by using abemaciclib. At 7 years, it was 79.5% for endocrine therapy alone versus 74% for endocrine therapy plus abemaciclib, meaning that abemaciclib have helped to reduce the risk of distant recurrence by 5.5%. In relative terms, translating 26.4% reduction in the risk of distant relapse by using abemaciclib in addition to endocrine therapy. So all of these are related to efficacy data of abemaciclib in the adjuvant setting in high-risk endocrine therapy, or hormone receptor positive breast cancer. Defining high risk are those who have N2 disease, N1 with a tumor size 5 centimeter or above, or N1 with grade 3. So it helped to improve the invasive disease-free survival, overall survival, and distant disease-free relapse or recurrence. So what about safety data? Is it safe to use abemaciclib? If you look at the grade 3 and above toxicity, you can see that the most reported toxicities are diarrhea and neutropenia. Most of the neutropenia cases were asymptomatic neutropenia. It was only the numbers on the screen that we see when we do CBC for these patients. And diarrhea, lucky enough that we have effective treatments that we can use as a prophylaxis, whether primary or secondary prophylaxis to treat diarrhea. Most importantly, and I have to remind myself and remind my colleagues from medical oncology side, feel free to reduce the dose of abemaciclib whenever patient is suffering significant toxicity. We as medical oncologists have a wrong belief that reducing the dose may affect the outcome and the benefit of abemaciclib in the adjuvant setting, which is not true. I will show you a slide at the end of this talk that will show you clearly by reducing the dose, because of toxicity and adjusting the dose according to patient tolerance, this will not affect the benefit of using abemaciclib, whether in early breast cancer or metastatic breast cancer. If you look at the monarchy trial, you can find that 82% of patients with proper dose adjustment and proper management of toxicities were able to continue the abemaciclib without discontinuation. A real-world study, it was up to 88%. They were able to continue abemaciclib. In my own clinical practice using adjuvant abemaciclib, in my patients, I hardly can recall a patient who stopped abemaciclib permanently. I had one patient only who elected by her own to stop, but the vast majority of patients were able to continue with proper medications to treat the toxicities and with proper dose adjustment of abemaciclib whenever toxicity arises. So a real-world data, again, you can see that 93% of patients have been subjected to dose reduction because of toxicity. So this will encourage adherence of patient to abemaciclib. So remember, the adherence to abemaciclib by proper dose reduction is more important to continue the standard treatment dose that will lead to interruption and permanent discontinuation. So feel free to reduce the dose if there is significant toxicity. The median time for dose reduction was in the range of 2 months. What about the quality of life? As you can see, once again, if you properly use abemaciclib with proper dose reduction and proper supportive medications for toxicities, you can see the quality of life did not change significantly or was not negatively impacted by using abemaciclib in addition to endocrine therapy backbone. So the quality of life was maintained and it was in good shape. So abemaciclib in early breast cancer, luminal breast cancer, high risk, as we define by N2, N1 with a tumor size 5 centimeter and above, N1 with a grade 3, has a proven long-lasting protection. As we have seen at 7 years, there was an improvement in invasive disease-free survival, overall survival, and distant free recurrence. And you can see also the safety profile was quite manageable with dose reduction and proper medications. And furthermore, it is recommended by all prestigious international guidelines. As we know, the ASCO, NCCN, ESMO, and the St. Consensus Panel, all of them, they recommend using abemaciclib in the adjuvant setting of high-risk hormone receptor-positive breast cancer as a preferred treatment option. I always like to put in a table to summarize all biological treatments that can be used in high-risk hormone receptor-positive breast cancer, including olaparib, abemaciclib, and ribociclib through different clinical trials, different population, different definition of high-risk features, different biological agents, and different duration of treatment, 1 year, 2 years, 3 years, respectively. And you can see that all these biological agents have achieved their primary endpoint with regard to invasive disease-free survival. However, when we talk about overall survival, only 2 of them have shown survival benefit so far, which is olaparib and abemaciclib. And the toxicity profile might be different according to the underlying biological agent. So you can choose among these biological therapies to consider definition of high risk, whether your patient fall in this kind of definition or not, to consider dosing and frequency, consider the total duration of the biological treatment, 1, 2, or 3 years, and to consider precision oncology approach. For example, olaparib is specific for BRCA mutant patients, and to consider the clinical benefit, toxicities, including financial toxicity, and most importantly, availability of these biological agents in your institution and clinical practice. I'll give you like an example of 3 patients in my clinical practice. The first patient here, you can see that she has a node-positive disease, like 3 out of 13 lymph nodes in one disease, and she has grade 3. So this will fulfill the criteria of using abemaciclib as per the monarchy trial. The second patient had N2 disease, but she is BRCA negative. So she's not qualified for olaparib because she's BRCA negative. However, she's qualified for abemaciclib and potentially for ribociclib. And finally, you have a patient who has N2 disease, as you can see, 6 out of 13 lymph nodes, and she's BRCA positive or BRCA mutant. Then this patient will be available or will be candidate for all these like biological treatments, abemaciclib, ribociclib, or olaparib because she is BRCA mutant. And as I mentioned, you can choose your biological treatment according to the efficacy data, the wealth of information, and toxicity and duration of treatment, as I mentioned above. Let's move on to the metastatic luminal breast cancer. We know that the standard of care in metastatic hormone receptor positive breast cancer nowadays is to use aromatase inhibitor plus anti-CDK4/6 in the first line. And one of the most influential studies that have established this practice and this belief was the MONARCH 3 trial, which have tested abemaciclib plus aromatase inhibitor in endocrine therapy sensitive patients. So 100% of patients have been included in this study were endocrine sensitive. And 53% they have visceral disease. We know that visceral disease, usually we look at them as more poor prognostic kind of group of patients in comparison to those who have bone-limited disease. So they have included up to 500 patients who have been randomized 2-to-1 to receive abemaciclib plus aromatase inhibitor versus aromatase inhibitor alone. The primary endpoint was progression-free survival. If you look at the progression-free survival, you can see that those who have been treated with aromatase inhibitor had almost 15 months versus almost 30 months for those who received abemaciclib plus aromatase inhibitor. So there was a doubling of progression-free survival, translating into 46.5% reduction in the risk of disease progression by adding abemaciclib to the aromatase inhibitor backbone. Furthermore, if you look at the response rate here, you can see the response rate has improved from 45% for aromatase inhibitor to almost 61% for abemaciclib and aromatase inhibitor. Remember, the chemotherapy in hormone receptor positive breast cancer usually will give you a response rate somewhere between 35 to 40%. And here, by using abemaciclib and hormone and endocrine therapy, you can achieve up to 61%. So this is a very effective strategy to induce response for those patients who have a high volume of disease if they have a hormone receptor positive breast cancer with metastasis. When it comes to one of the key secondary endpoint is overall survival, you can see that the overall survival for those who was treated with first line aromatase inhibitor was 53.7 months versus 66.8 months for those who have been treated with aromatase inhibitor and abemaciclib. So the absolute difference you can see is almost 13.1 months. So 1 full year or over 1 year have been gained for those patients in the lives of those patients by adding abemaciclib to the aromatase inhibitor in the first line for those patients who have been treated with this combination, which is clinically meaningful for us as medical oncologists and more importantly for our patients. And this kind of benefit, as you can see, was shown in most of the subgroups, including those who have visceral metastasis, as you can see here, and the overall survival for those patients who have visceral disease was 63.7 months total. If you tell me 10 years ago that metastatic breast cancer with visceral mets, even if they have luminal breast cancer, they have a median survival that exceeds 5 years, nobody would believe that. But fortunately, with all of the advances that we have nowadays, including the addition of abemaciclib in the first line setting, our patients can achieve more than 5 years of median survival, despite the fact that they have visceral disease. And with regard to the toxicity, as we mentioned before diarrhea and neutropenia, which can be easily managed by supportive medication and proper dose reduction if needed. If you go back to the benefit of addition of abemaciclib, as you can see, when we talk about abemaciclib plus aromatase inhibitor in the first line for endocrine sensitive patients, the progression-free survival was approaching 29 months and overall survival was 66.8 months. If you consider those who have visceral disease, the median survival was approaching 63.7 months. So over 5 years for visceral disease in the first line setting if you use abemaciclib plus aromatase inhibitor. On the other hand, if you consider abemaciclib plus fulvestrant for those who have endocrine therapy resistant disease, i.e. in the second line setting as per the MONARCH 2 clinical trial, you can see that the progression-free survival has achieved 17 months and 46.7 months for overall survival. If you consider those with visceral disease, it was approaching like 40.3 months as a median survival for visceral disease who have been treated with abemaciclib in the second line, second or first line for endocrine therapy resistant patients. And this is the design of the MONARCH 2 trial that have included those patients who failed prior endocrine therapy, whether aromatase inhibitor in the adjuvant setting or first line aromatase inhibitor in the metastatic setting. You can see that almost 60% of those patients, they received the fulvestrant abemaciclib in the first line setting, meaning after failure of adjuvant aromatase inhibitor, and 56% that they have visceral disease. Those patients have been randomized to fulvestrant alone or fulvestrant plus abemaciclib with progression-free survival as the primary endpoint. And once again, we talked about the benefit previously when it comes to progression-free survival, overall survival, including the overall survival for those who have visceral disease, which was clinically and statistically significant in favor of adding abemaciclib to fulvestrant in the second line setting. Likewise, the toxicity, as we spoke in the MONARCH 3 and MONARCH, and how to manage the toxicity when it comes to diarrhea and neutropenia. So when we talk about safety profile of abemaciclib, most of these adverse events were generally reversible with co-medication and dose adjustment, and the quality of life and patient-related outcome findings showed that quality of life is maintained and support the use of abemaciclib in these different indications, and adjusting the dose early in the treatment will help adherence of patients to continue abemaciclib and will not affect the outcome of the use of abemaciclib. Abemaciclib was associated with less drug interaction in comparison to other CDK4/6 inhibitors. The classic dose of abemaciclib is 150 milligram twice daily, and it can be used irrespective of food timing, and it can be adjusted and reduced to 100 milligram twice daily and 50 milligram twice daily if clinically indicated by patient-reported outcomes and toxicities. And the pill has to be swallowed as a whole, shouldn't be crushed and shouldn't be broken before eating. And this is the table that I want to refer to when it comes to the dose reduction. If you compare the standard dose of 150 milligram twice daily of abemaciclib to the dose reduction, whether 100 or 50 milligram or twice daily of abemaciclib when patient develop toxicity, and this is true in early breast cancer and metastatic breast cancer, you can see the hazard ratio here. There is no negative impact on the outcome of these patients. So it is very important to reduce the dose whenever is needed to enhance the adherence of the patient to continue this kind of treatment. And as I mentioned, the dose is 150 milligram twice daily. That can be reduced to 100 or 50 milligram twice daily. The duration of abemaciclib in early breast cancer is 2 years for metastatic breast cancer until disease progression. And this table summarizes the different clinical trials of different anti-CDK4/6, whether first line or second line, with the outcome and the benefit of using these medications. And you can see clearly one of the most beneficial anti-CDK4/6 was abemaciclib, whether used in the first line or second line setting. I want to share quickly this patient with you. She's one of mine, 62-year-old postmenopausal lady diagnosed in January 2024 with an invasive ductal carcinoma grade 2 ER/PR positive, HER2 low, Ki67 of 34 to 40%. Initial staging showed multiple bilateral pulmonary nodules and diffuse peritoneal disease with moderate ascites and bone metastasis. And final diagnosis showed that she has luminal breast cancer, HER2 low, with de novo metastatic breast cancer disease. The treatment was initiated in January 2024 using letrozole, abemaciclib, 150 milligram twice daily, which was subsequently reduced to 100 milligram twice daily, and denosumab of 100 milligram Q4 weeks. Radiological response. In April 2024, she had the first reassessment CT scan, which showed marked response, near complete ascites resolution. 4 months later, in August 2024, she had further response with almost complete resolution of her primary breast lesion and peritoneal disease, and she was kept on surveillance every 3 to 4 months. The last CT scan was done in November 2025, which showed stable disease. The only toxicity reported was mild nausea, which was quite manageable with the anti-nausea medication, and grade 3 neutropenia, for which the dose was reduced from 150 to 100 milligram twice daily. And the current plan is to continue our current therapy with CT scan scheduled actually next week or in the next 2 weeks to assess treatment response. So to summarize, abemaciclib, it has proven efficacy across different phase 3 trials, monarchE in early breast cancer, monarch-3 in endocrine-sensitive metastatic breast cancer, and monarch-2 endocrine-resistant metastatic breast cancer, multiple endocrine therapy options, tamoxifen, aromatase inhibitor, and fulvestrant, and long-term safety data as you have seen in the previous slides. With that, I would conclude my talk, and thank you for your attention.
Thank you, Dr. Ahmed. Now the floor is open for questions. Yes, please, Dr.
Thank you, Dr. Ahmed. It was very comprehensive and amazing talk as usual. Dr. Ahmed, about abemaciclib, and when presented as phase 1 trial, there was some hints that it has the unique feature of penetration of blood-brain barrier and maybe helpful for, we expected even that in the phase 2 and 3 trials, they will include brain metastatic patient in these trials, but it was exclusion criteria. So do you think that when we have patient with brain mets after control of these mets, might be abemaciclib a better option for them? This is the first question. And the other point about the survival data of monarch-3, what is your insight about these results of survival data? Thank you.
Thank you, Prof. Ahmed Badib. Smart questions as always. Barakallah feek. Regarding the brain activity, I didn't mention that because it's not one of the approved indications as per our local kind of authorities, and this is why I didn't present these data. But I totally agree with you. There have been phase 1 data that have mentioned that abemaciclib, even as a monotherapy, might have like a clinical activity inside the brain, unlike the other CDK4/6, where we don't have sufficient data to support such use. So to answer your question, yes, among the different CDK4/6 inhibitors, you have like 3 of them They are different with regard to the clinical efficacy data. They are different with regard to their toxicities, drug interactions, the scheduling. Some of them are continuous schedule like abemaciclib. The other two, they have interrupted schedule. Some of them like twice daily, some of them once daily dose, some of them once pill a day. The others may have 2 or 3 pills a day. And one of the differential factors to choose among these might be the brain metastasis. So I totally support your idea, Dr. Ahmed or Prof. Ahmed Badib. If I have a patient who might have brain metastasis, which was locally treated by local regional treatment, whether surgery or stereotactic radiation, and I wanted to start like one of these anti-CDK4/6, abemaciclib might be a preferred option in these patients who have brain metastasis, in my opinion. With regard to overall survival data of the Monarch 3, you can see that there was like almost 13.1 months difference between those patients who had abemaciclib plus aromatase inhibitor versus aromatase inhibitor alone in the first line setting. I have to remind myself and everybody that the primary endpoint of the study was progression-free survival. Overall survival was not the primary endpoint, so the study was not powered enough to show the overall survival from a statistical point of view. However, this kind of 1-year difference between the 2 treatment arms is clinically meaningful in our clinical practice for us and for our patients. So in my humble opinion, I think this is clinically meaningful and important to our patient. I would consider that a very positive signal about the efficacy of abemaciclib in this clinical scenario.
If no more questions, thank you, Dr. Ahmed, for this comprehensive review as usual, and see you tomorrow, inshallah, or see you after a while in another lecture. Thank you. Now we'll move on to the next satellite symposium, this one sponsored by Pfizer, and it's mainly about the revolution in the management of HER2-positive breast cancer. I'm glad to introduce Dr. Ammar Al-Shihri. Dr. Ammar is a consultant of adult medical oncology at King Fahd Medical City, Riyadh. Dr. Ammar will talk about the revolution in the HER2 advanced breast cancer. He will mainly talk about tucatinib empowering the first the fight against HER2 metastatic breast cancer. Dr. Ammar, please.
Assalamu alaikum. Good evening, everyone. Thank you, Dr. Nafisa, for the introduction. And thanks, Pfizer, for the invitation. So my topic today is going to be HER2 positive metastatic breast cancer. So I'll just establish the background of HER2 positive breast cancer. I'll speak a little bit about tucatinib and the second line and beyond. It is approved medication, and the NCCN has for the metastatic breast cancer HER2 positive with CNS metastasis in the second line based on the HER2 CLIMB, and also is approved as a third line for metastatic HER2 positive breast cancer with systemic disease. As it shows here, the study shows overall survival benefit, and it has been the practice since the approval. And this is overall survival updated. The last one was 24 months versus 19 months. And also, tucatinib and the HER2 CLIMB has included patients with active CNS metastasis. And what I mean about active CNS metastasis is patients are symptomatic from the brain metastasis. And this medication has activity with patients with CNS metastasis. So now, it's 2025 is more interesting year. It used to be the standard of care is Cleopatra protocol since 2012. And we have a couple of studies that has been approved in the last 2 years. The latest one was the HER2CLIMB-05, which is utilizing tucatinib in the maintenance phase in the first line. So induction phase with THP and 6 to 8 cycles or 4 to 8 cycles, followed by maintenance HP plus tucatinib. And also there is another trial, which is the Destiny-09. It is TDXT from the early beginning. And earlier trial also is almost similar to the HER2CLIMB-05, utilizing the palbociclib and the triple positive breast cancer. So this is the paradigm right now, and a lot of things are changing for the last 1 year. So speaking of these agents, TDXT is antibody, monoclonal antibody, and tucatinib is a small tyrosine kinase inhibitor, highly selective for HER2, less selectivity for the EGFR. That's why has less, it causes less diarrhea compared to the other anti-HER2 TKIs, and also has CNS activity approved by clinical trials. And the palbociclib, as you know, is a CDK4/6 inhibitor. It inhibits the CDK4, the cyclin D1. And causes cell cycle arrest at the G1 phase. So the HER2CLIMB is a phase 3 double-blinded trial studying tucatinib plus trastuzumab pertuzumab versus placebo trastuzumab pertuzumab. It has been presented in the latest San Antonio last year. And the study design is 2 arms, starting with induction phase 4 to 8 cycles, followed by the intervention arm, tucatinib plus trastuzumab pertuzumab. The dose of tucatinib is 300 milligram BID, and comparing to placebo trastuzumab pertuzumab. And initial overview about the study: the hazard ratio is significant, 0.641. With significant p-value, the intervention arm had more benefit in terms of progression-free survival, 24 months versus 16 months. And as I mentioned to you, the induction phase followed by the maintenance phase, and the unmet need and the maintenance phase is optimizing the maintenance, trying to delay the progression. The rationale of this to enhance even further blockade of the HER2 receptor from the extracellular domain, further enhancing the blockade into the intracellular domain. This is the study design, the induction phase, as I mentioned again, 4 to 8 cycles, and then the eligibility check, which they include the patient only who had complete or partial or stable disease. Those who had progressive disease, they were excluded from the trial, and they ended up with almost 650 patients to the experimental and control arm. And the primary endpoint was progression-free survival, secondary endpoint overall survival, CNS PFS, and of course, safety. So these are the stratification factors. They stratified patient based on diagnosis, whether it is de novo or recurrent, the hormone receptor status, and the brain metastasis, if it is present or not, and the treatment details, as I mentioned to you, and endocrine therapy has been permitted to utilize in the study. The median age of the population was 54 years old. A majority of the patients, almost 69%, they were de novo, upfront metastatic presentation. 53% of the patients were hormone positive. And also they have included patients with brain metastasis, accounting for 12%. And small or minority minority in the population, they were had treated curatively, almost 27%. This is the progression-free survival. As you can see, the hazard ratio is 0.64, decreasing the risk of progression by almost 35 or 36%, with a delta between the intervention arm and the placebo arm almost 8.6 months. And this result has been confirmed by independent reviewer. The same hazard ratio has been found. There is a 28 months benefit in the tucatinib arm versus 16 months in the placebo. And this is the subgroup analysis. You can see the tucatinib arm is favoring, or the first plot is toward the tucatinib, regardless of the subgroup, whether they are de novo, if they are hormone positive or negative. Maybe the benefit is more pronounced in the hormone negative HER2 positive breast cancer, and the brain metastasis as well. They had benefit, and whether they have visceral disease or non-visceral disease. More in depth in the hormone status, hormone negative has a ratio of 0.5, while hormone positive has a ratio of 0.72, indicating that in the subgroup analysis, the hormone negative patient, they derive more benefit from the tucatinib arm. And this is the CNS progression-free survival. As you can see, almost is doubled compared to placebo, 8.5 months compared to 4.3 months, with significant hazard ratio. I have to say that the number of patients were 81, and as you can see, the confidence interval is a little bit wide, maybe because the number of patients is not powered enough to represent statistical significance, but again, there is a signal to improve the CNS disease. And the overall survival, as you can see, is still immature, but you can see clear separation of the curves with the hazard ratio of 0.53, indicating this intervention might prolong life. The safety of the medication, the grade 3 toxicity was almost 42% of the intervention versus 24% in the placebo. These are the grade 3. The serious one was 16% versus 8%. And the discontinuation due to adverse event almost was 13% versus 4.6%. However, the most common side effects were diarrhea, including 72%, nausea, 33%, ALT increase, 28%. The diarrhea was majority of these grades were grade 1 and 2, and they were controlled with anti-diarrheal medication. And these are the diarrhea, as I mentioned to you. Majority of them, they were like grade 1 and 2. As you can see here, the grade 3, almost 6% versus 4%. As you know, that pertuzumab can cause diarrhea as well. ALT increase, and AST is almost ALT, let's say like 28% versus 7%. Primarily, all these side effects were manageable, and they were reversed with the dose interruption and dose reduction. Dose holds occurred almost 50% in the trial, and dose reduction almost 29%. And the median duration of treatment was 17 months on the tucatinib versus 15 months. This is longer treatment duration, indicate that these adverse events are tolerable and more patients actually alive in the treatment arm. As you can see, these are, I've spoken about 3 trials. The progression-free survival is different in all these trials. As you can see here, the Cleopatra is 18 months, all the Cleopatra, while the control arm in the Disney is 26 months, Patina 29 months, and HER2 climb is 16 months. So you can't compare head-to-head clinical trials since the progression, the control arm is totally different. One of the study population limitation is they have excluded patient has progressed during the induction phase. The study design, they didn't cross over, and the endocrine therapy, there is like low utilization of endocrine therapy, less than 50%. And of course, we are waiting for more time to see how is the overall survival. So in conclusion, there is significant benefit in addition of tucatinib to maintenance phase, trastuzumab, pertuzumab, almost 36% risk reduction of progression. And that has translated into 8 months delta between control and intervention arm, and the benefit has been observed across the board, and the safety, generally speaking, from our experience and from this trial, the treatment or medication is safe, and the side effect can be managed with dose hold and dose reduction. Quick overview about the DESTINY is again is a phase 3 is TDXD plus pertuzumab from early beginning compared to the control arm with taxane trastuzumab for 6 to 8 cycles, followed by maintenance phase trastuzumab, and this result or this study actually resulted into improved progression-free survival, 70% versus 52% with a significant hazard ratio. Hazard ratio is 0.56. And the objective response rate is more with TDXD plus pertuzumab, and more patient had complete response, almost 15% versus 8%. Again, you know, the interstitial lung disease, the typical adverse event with TDXD is most come to 12%, and there is 2 mortality in the treatment arm. Nausea was quite common, almost 71%. Neutropenia, 23%. And patient selection is important, excluding patient with high risk of lung disease or has pre-existing interstitial lung disease, and always prepare for higher pre-medication for nausea and vomiting. And the BATINA trial, which is the third trial that I want to really highlight, is addition of palbociclib along with trastuzumab, trying to prevent the crosstalk resistance. And if you block the HER2 receptor and triple positive, this might upregulate the estrogen receptor and causes disease progression, and addition of palbociclib felt to be reasonable in this trial. And it actually showed a positive results with a delta between the intervention and the control arm, almost 15 months with a hazard ratio of 0.75. The most pronounced side effect in the BATINA was the neutropenia, it's almost 79%, and majority of these side effect or the neutropenia was grade 3 and 4, meaning that the ANC is less than 1,000, but it didn't translate into febrile neutropenia and deaths. So now we have, and also as you can see that the discontinuation rate in the palbociclib was 13%. Some other side effect has been also observed, like diarrhea, but it's not translated into like grade 3 or significant grade 3 is almost 6%, elevated ALT 28, and elevated AST 25%. I mean, it's manageable with dose hold and dose reduction. So this is like a table, a nice table comparing all these 3 medications. TDXD ILD is a red flag. It might occur up to 12%. Palbociclib, it might cause neutropenia. Also, TDXD causes significant risk of nausea. Almost 71% is highly emittent medication. And it also causes alopecia as well. Tucatinib, diarrhea, 73% is irreversible, and hepatotoxicity is a grade 1 and grade 2, and it's manageable with dose halt and dose reduction. And all these these new strategies had added benefit on the THP protocol or the Cleopatra protocol. And as you can see, all of these trials, or whether the strategy of maintenance with Balbo or Tucatinib, or whether you start from early cycle, from the early beginning with TDXD, all these strategies has improved the standard of care. This is almost the last slide, and this is like a suggested approach. We are still awaiting approvals, a lot of discussion about these new agents and new trials, who is getting Tucatinib, who is getting TDXD, who is getting also Valociclib. And from my opinion, humble opinion, the high burden disease, the highest risk patients, those who has more than 3 signs of metastasis, liver, lung, pre-existing multiple brain lesions, those who are getting TDXD, because you are commencing high-risk medication. And as we know that those patients with limited disease, like bone limited or metastasis, like lung or let's say less than 3 signs of metastasis, they have overall survival, long overall survival with the traditional HP maintenance. They might reach up to 5 years if they have really limited metastatic disease. So it is a bit more aggressive and might be over-treating them with TDXD. So you need to select carefully those who has potentially intermediate risk that you feel with predictive scores that you calculate for them, they will recur, then you may add Tucatinib. And also the triple positive patient, if they are triple positive, I think addition of also Valociclib is felt to be reasonable. However, monitoring CBC is important. As I mentioned to you, that TDXD is important medication with a hazard ratio of 0.5. And it's challenged the taxane. However, it's a toxic, and you might commit the patient for toxic medication for long time. And we should optimize the maintenance phase with CDK4/6 inhibitor and the Batinib trial, or the Tucatinib based on the HER2/5 trial. And the future and the success is choosing the right patient for the right regimen. With this, I end my presentation. Thank you so much.
Thank you, Dr. Ammar, an excellent talk, really. And now the floor is open for questions. If anybody has questions, yes, please.
Thank you, Dr. Ammar. Really, you covered all the aspects of and really, we are very happy with this presentation because it was very teaching one and covering all the aspects of the treatment. Just for the algorithm, do you think that consideration of this approach for hormone negative cases might, based on the hazard ratio that we have, will be the most suitable patient, hormone negative rather than, and keeping Batina for hormone positive? Do you think that?
Yes, I think that's a very reasonable approach. If we keep the Balbo for the triple positive. However, in the HER2 climb, 50% of the population, they were HER2 positive, hormone positive, sorry, and they allowed for hormonal treatment. If you feel the patient is at higher risk for CNS metastasis, then you may even utilize tucatinib in the triple positive breast cancer. I looked into risk assessment calculator module, predicting which is low risk, which is intermediate, and which is high risk, validated in the Nature journal. It is based on retrospective study. It's a Chinese study, included 300 patients. They formulated a tool, almost 5 elements: patient age, pre-existing CNS metastasis, if they have received radiation therapy for this CNS metastasis, and equal performance status, and and more than 3 metastatic sites. And it has classified patients to low, intermediate, and high risk. And those who are low risk were 2 points, and they lived up to 30 months. Intermediate risk were 20 months, and high risk patient, they lived up to 10 months, which is based on the overall survival. And you may utilize such tools. Yes, I know it's based on Chinese population only, but again, you can extrapolate and use this tool to help you to decide who is really having higher risk for CNS metastasis, and you may offer tucatinib for them.
One quick comment.
Thank you, Dr. Omar, for your elegant presentation. You just mentioned this Chinese, classification for the prognosis for overall survival for patients with CNS metastasis, like the recursive partitioning analysis, or this is to expect the eruption of brain metastasis?
This is expecting the eruption of brain metastasis. Yes.
Okay.
And as you know, that the correlation between CNS disease and survival is they are strongly associated. Those who has CNS disease, they have dismal prognosis and worse prognosis.
Yeah, because really, I think a patient with HER2, even small tumors, even if, low tumor burden, the CNS metastasis can happen all the time. It's really very difficult to just expect which patient who will develop metastasis. And usually the patient who develop metastasis, those who just receive the treatment for long duration, who lives long enough to just survive systemic treatment, so the CNS to pop up after that. Thank you so much.
Dr. Ammar, maybe tucatinib was added to Herceptin, pertuzumab, Cleopatra, which might not be the standard of care soon. Destiny-09 is on the road, coming very fast and with very good PFS, like 1 year difference from Cleopatra. So where do you see tucatinib from that? Are we going to go to the same sequence like before, or we might add it to TDXD later, or just having it as maintenance after TDXD? What is your insight about this?
Well, if we utilize TDXD, the first line, then tucatinib is the second line. But I will be really careful whom I will select for TDXD, honestly speaking. We know some of the patients on HP, they stay disease-free or stable disease for a long time. And there is cumulative toxicity with the ADC, nausea, alopecia. Also, the risk of IND is dose-dependent, cumulatively increasing with the doses. I'll be selecting TDXD for the highest risk patient, while I will choose the maintenance strategy for those who are relatively, I think that, or I feel that they are at lower risk for CNS disease. Tucatinib going to be a second line if TDXD is utilized first, especially when there is CNS disease. Also, I would like to emphasize that the importance of local therapy in terms of surgery, stereotactic, also radiation, whole brain radiation. These local therapy has overall survival benefit. So we need also to optimize it along with the systemic treatment.
Yeah, I agreed. Thank you, Dr. Ammar. Thank you so much. And I think by this we can conclude our session and move to the next session, please. Thank you.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين. First of all, I would like to thank the organizing committee for their kind invitation. Dr. Nafisa Abdel Hafiz. I am Dr. Ahmed Rifai, consultant clinical oncology at King's College Hospital, London, Jeddah. And I am really honored to have my co-chairman, Prof. Ahmed Badib. We will just start for our second session, which is concerning the advances in adjuvant systemic therapies for breast cancer. And we are honored to have our speaker today, Dr. Mariam Lustberg. She is the Chief and Director of Breast Oncology Center, Yale, at New Haven, USA, and she will start the first presentation. Dr. Mariam just will speak about the role of ADCs in the adjuvant and neoadjuvant setting. And also she will have another talk about the role of immunotherapy in early stage triple negative breast cancer. Dr. Mariam, the mic is yours.
Shukram. Salam alaikum. Thank you so much for the invitation. I'll be speaking about the role of ADCs in early stage breast cancer. My disclosures are listed here. And the focus of the talk will be primarily in early stage HER2 positive breast cancer, but I will bridge briefly to triple negative use, which will also help us transition to the second talk on the role of immunotherapy in triple negative early stage breast cancer. So starting with early stage HER2 positive breast cancer, the proportion of patients that are classified as HER2 positive is well known to this audience. This has become one of our, used to be our most aggressive subtype of breast cancer, and due to advances in therapeutics, it has become one of our best prognosis due to the emergence of these very targeted therapies that precisely target the HER2 pathways. We'll start out a little bit historically, very quickly, talking about where we have been. The HER2 regimens have been evolving very rapidly in the last several decades. We used to give a lot of anthracyclines, and depending on where you're practicing, you may still be. But there are a body of data now supporting that we don't have to use anthracyclines in the majority, if not all, the cases of HER2 positive early stage breast cancer. There is emerging data that carboplatin backbones may add more toxicity and less benefit. So the data continue to mature, suggesting that for many of our patients, we could consider removing carboplatin from our traditional chemotherapy backbones. An emerging area, which we won't spend too much time talking about, but you will be continuing to hear a lot about this, is the emerging role of ctDNA as a way of guiding our therapy decisions in early stage breast cancer. This is right now in the clinical trial phase, but we are seeing quite remarkable data, and I'll show you briefly one slide on this. And then, of course, we will talk about the expanded role of ADCs in HER2 positive breast cancer. There was a very nice session in the San Antonio Breast Conference just a month or two ago talking about moving on up, where the role of ADCs continue to move up to earlier and earlier stages of HER2 positive breast cancer, as well as other subtypes of breast cancer. Prior to some of the newer data with both DESTINY-05 as well as DESTINY-11 that first emerged in ESMO, really the way that we traditionally treat HER2-positive breast cancer is that the very small tumors, T1A, T1B, and most T1Cs go to surgery first, and then we select a type of HER2-directed therapy, either a taxane-based therapy, or I'll show you some data from the ATTEMPT studies where TDM1 could be selected. For T2 tumors or larger, the standard has been for many years now that we want to give a preoperative approach with HER2-directed therapy. And these preoperative approach backbones have been changing with kind of moving away from the anthracycline-based, the carbo-based regimens. And we have been really thinking about how to optimize the care of patients with residual disease, with the current standard being TDM1 for patients with residual disease, but certainly we'll talk about how DESTINY-05 is changing that. This is the same principles highlighted in the current ESMO guidelines for your reference. The mechanism of ADCs or antibody-drug conjugates is well known to this audience, but is really principled around the principle of the target being HER2 in the case of HER2 ADCs, internalization into the tumor cell, detachment from a very specific linker, and then the release of the payload centered in the HER2-positive cells, and then diffusion into bystander cells. The first ADC approved in HER2-positive breast cancer is TDM1. It was a very old technology. It was effective technology, but compared to some of our newer ADCs, the linker technology was not as robust. But TDM was one of the first ADCs approved in breast cancer. And there were a number of studies evaluating the use of TDM in early-stage breast cancer, including the Christine study, which started asking the question, what if we used an ADC in combination with pertuzumab in place of our traditional taxane-containing, platinum-containing HER2-targeted therapy approaches? And the results were disappointing at the time. It was pushing the envelope, but the PCR rates were certainly lower than our traditional chemotherapy. And I think as data have matured, I think this is more the reflection of the ADC TDM1 not being as good an ADC as some of the other, like the trastuzumab deruxtecan that you will hear about. There was a lot of thought about how TDM could be used in lower risk early stage breast cancer, and the ATTEMPT trial took patients with early stage HER2 positive breast cancer and randomized them 3-to-1 to TDM1 versus the APT regimen of taxane plus Herceptin. And the results were excellent. The quality of life of patients receiving TDM by patient-reported outcomes were actually superior to traditional chemotherapy. In terms of significant differences in terms of protocol-specific chemotherapy-related toxicities, there was not a significant difference between the two regimens. And the thinking was that just a year of TDM1 is just very long, and the toxicities can add up. And this has led to the ongoing US-based ATTEMPT 2.0 study, where patients with stage 1 HER2-positive breast cancer are randomized 3-to-1 to 6 cycles of TDM1, followed by subcutaneous trastuzumab, compared to the traditional TH regimen. So we will await results of this study, but much better tolerated when only 6 cycles of TDM1 are given. You're all familiar with the Catherine study, which really changed the standard of care for administration of TDM1 for patients with residual disease. And in the last year, we have overall survival advantage confirmed for this group of tumors. So moving on to our new star ADC, which is the trastuzumab deruxtecan. The linker technology is much better. It has a very highly potent topoisomerase inhibitor payload. The specificity for the target is much better. So all of these really have led to very different results than what we initially saw with TDM1. So I will review those results with you now, starting with the Destiny 11 study, which asked the question, what if we included TDXD by itself versus TDXD followed by THP, comparing it to one of our oldest neoadjuvant regimens in HER2 positive disease, which included anthracyclines followed by THP. This was a higher risk population, including tumors that were at least T3 if they were node negative, or node positive disease or inflammatory breast cancer. Wanted to draw your attention that this did not include clinical T2 node negative patients. So they were randomized 1-to-1, and the results, as you have seen, is that the TDXD ADC only arm was actually discontinued because of much lower PCR rate of 43%. So that arm of the study was terminated early. But for patients who received TDXD for 4 cycles followed by THP, you can see a dramatic increase in PCR rates, particularly in that hormone negative subset of tumors with PCR rates of 83% and 61% in the hormone receptor positive. The composite PCR rate was at 67%. Grade 3 toxicities are listed here, and as you can see, this was being compared to one of our hardest regimens, which is a 3rd-generation regimen with anthracyclines and taxanes and dual HER2 targeted therapy. So in some ways, many have argued that was this a fair comparison, but comparing to what this regimen was, TDXD THP actually in many ways had a more favorable toxicity profile compared to a more difficult anthracycline based regimen. Interestingly, because we are concerned about ILD risk with TDXD, patients received CAT scans serially during this protocol every 6 weeks. And so they actually identified ILD cases even in the AC THP arm, which we normally don't associate with. So as you can see, the grade 3 events are listed there. 1 patient in each arm, TDXD THP and the dose-dense AC THP, unfortunately passed away from complications of either regimen. And so I mean, yes, 1 person is too many. And so it really still highlights that we have to select the right patient for the right protocol, as our previous speaker nicely put. What about the patient experience on Destiny 11? Again, comparing to one of our hardest regimens with anthracyclines, the proportion of patients who were able to maintain their quality of life on the ADC-based regimen was actually quite good. These waterfall plots show the up and down ebb of toxicity experience with TDXD, where patients tend to kind of have more trouble mid-cycle, and then they tend to recover and feel quite good right before starting treatment. So compared to an anthracycline-based regimen, actually patient-reported outcomes were reporting less toxicity and more severe toxicity that was bothersome in the TDXD THP arm. So moving on to adjuvant use in higher risk disease with residual disease, this brings us to the Destiny 05 study. We saw the Catherine study with TDM1. Now that we have a more robust ADC, the question here was, can we improve on the results of the original Catherine study, where patients with very high risk disease are randomized 1-to-1 to TDXD versus TDM1? I wanted to highlight the eligibility criteria, which included inoperable early breast cancer. We're looking at those inflammatory breast cancers, T4 lesions, very high N2 or N3 disease, or patients who, after neoadjuvant therapy, had at least node-positive disease. So it's really important to kind of highlight this very much higher risk population. And the results were impressive. There was an 8.7 absolute difference in improvement in invasive disease-free survival when TDXD was given to this higher risk population. When we look at the invasive distant-free survival events, there was a significant reduction in both non-CNS as well as CNS events, highlighting the emerging known activity of TDXD having good CNS penetration compared to TDM1. So very, very, very promising results that we're seeing with a possible brain metastasis reduction when TDXD is given to this high-risk population. By subgroup analysis, this was seen improvement in all groups, and this was all very promising. There were more adverse events reported with TDXD, as you can see, with the exception of some of the hematological toxicities and liver function abnormalities that we traditionally see with TDM. One patient did pass away from in the TDXD arm, unfortunately, and an additional patient. So both whether the TDXD was given in sequence with radiation or concurrently with radiation, there were a total of 2 ILD deaths, again highlighting that we have to reserve this regimen for the higher risk patient. So summarizing our current status of HER2 ADCs in early stage breast cancer, we're doing less carboplatin. Adjuvant TDXD for 14 cycle is showing a statistically significant improvement in disease-free survival and should be considered for those higher risk patients as long as you have access to the drug in your region. In terms of when do we use neoadjuvant TDXD, this is still being actively debated among all breast cancer specialists. We still do not have the secondary endpoint of the disease survival events reported yet. So we only have PCR rates reported so far. It's not part of NCCN guidelines just yet. I have been able to get approval in the US for the very high risk inflammatory HER2 positive patients. It is a publication. The dilemma is selecting that very high risk patient and taking them through the Destiny 11 regimen, knowing that if they're more likely to achieve that PCR, they're less likely to need 14 cycles of TDXD on the back end. But it's very clear that not all patients need preoperative TDXD, and we really do need to understand the biomarkers of how to select patients. There are multiple other add-on strategies that are being looked at, particularly the addition of tucatinib to TDM1. This is the completed COMPASS residual disease study, which we are expecting. The hypothesis is that the addition of tucatinib in this early maintenance period could have additional synergy with TDM1 and how this performs relative to some of our current regimens. I think we'll have to await the data. The first data release is expected in the next year or so. I have here a comparison of all the different neoadjuvant HER2 positive regimens that I've read out so far. And yes, we know cross-trial comparison is not always a good idea. But I think the point here is that even with our less intensive regimens, there are patients, particularly those with hormone receptor negative HER2 positive tumors, that are able to achieve a complete pathologic response with less intensive regimens, sometimes as short as 4 cycles of THP. So this really comes back to we have to really identify that right patients. There are a number of new ADCs that are actively in development, particularly these bispecific HER2 antibodies, and the role of PI3K inhibitors is actively being looked at in HER2 positive disease. So this is a very rapidly evolving space. coupled with growing data on the role of circulating tumor DNA, helping us really potentially identify the patients who can get away with less therapy. These are results from the FIR-GAIN, FIR-GUIDE study that was presented in San Antonio. And by serially measuring circulating tumor DNA, the prognostic capability of circulating tumor DNA is clearly being shown here, that essentially the group that was circulating tumor DNA negative after completion of neoadjuvant chemotherapy prior to surgery really had the best prognosis. With a very simple non-ADC regimen, there was a 75% relative reduction in ctDNA positivity. So again, some patients definitely need more therapy, and so there's going to be a lot of ctDNA guided therapies that will be emerging. With that, I will segue into triple negative breast cancer and the next talk. But what we'll focus on is the different combination of ADCs and triple negative breast cancer. But concluding this portion of my first talk, these are exciting times for early stage breast cancer and ADCs. And our hope is that better tolerated ADC regimens and better biomarker will help us better select and personalize treatment. So I'll stop there and happy to move on to the second talk, depending on the chair's preference. And then we can certainly have additional discussion.
Thank you so much, Dr. Mariam. I think we can step into the next presentation, and then we'll keep all the questions at the end of the session.
Perfect. Thank you. So moving on to the role of immunotherapy in early stage breast cancer, the ADC story will be further elaborated on here as well. Again, this is well known to the audience that triple negative breast cancer is currently our most aggressive subtype of breast cancer, characterized by this early peak in recurrences that we typically see in those first few years. There are many different subtypes of triple negative breast cancer, with the basal subtype being the most aggressive. Sites of first distant recurrence include the brain, lung, and liver, and many unmet needs in terms of how we treat triple negative breast cancer. So lots of dedicated research going on globally in terms of how to define better targets and better treatment regimens. So the mainstay for many years for stage 2 and stage 3 triple negative breast cancer, as you all know, has been the use of traditional anthracyclines and taxane. For many years, the role of the carboplatin being added to this third generation regimen was debated for many years, and people went back and forth about, is it worth the toxicity to add carboplatin to triple negative regimens or not? However, in the current state of data, we really have good data that the platinums do add remarkable efficacy to these early stage high risk triple negative regimens. And so the summary of the different studies that have looked at the benefit of platinum in early stage triple negative breast cancer is summarized here for your perusal later at your leisure, showing that the addition of carboplatin does improve PCR rates and does improve disease-free survival. So, kind of looking at both kind of all the endpoints from event-free survival, disease-free survival, we can definitively say now that the addition of carboplatin does make these preoperative regimens a little bit tougher for patients, but does add that added benefit. But what about immunotherapy, which is what we're talking about today? I think it's instructive to go back to some of the older studies that really try to put immunotherapy on the map for triple negative breast cancer. For many years, single agent immunotherapy regimens were tried in breast cancer. We were trying to catch up to our melanoma colleagues and lung cancer colleagues. And it was only really when chemotherapy was combined with immunotherapy that we started to see kind of more of a signal that the chemotherapy is actually needed for that tumor lysis and antigen shedding to really make the immunotherapy more effective in triple negative breast cancer. So multiple studies have shown synergy between chemotherapy and immunotherapy. And of course, the current standard of care that all of you are familiar with is the Keynote 522. In the US, we have an expression that we call this everything and the kitchen sink. So as you can see, this includes anthracyclines, includes platinums, includes taxanes, and the addition of pembrolizumab given. And so essentially, this really allowed immunotherapy to enter the age of breast cancer care. This was in high-risk patients with clinical stage 2 or 3 breast cancer, and it included an adjuvant treatment phase of 9 cycles with pembrolizumab, regardless of the complete pathologic response. So the data have matured over time. We know that the addition of pembrolizumab improves complete pathologic response. We know it improves event-free survival. And then most recently, we actually have confirmed improved overall survival with a delta of approximately 5%. So really, the importance of this regimen in the care of patients with triple negative breast cancer is clearly been established. And we see this benefit really across all subgroups. And there has been quite a bit of debate about whether we actually need that adjuvant pembrolizumab, depending on the PCR rate. And so I'll talk about that data in a little bit. But really, across all groups, this event-free survival benefit is seen. This is a closer look at the PCR rates that you're familiar with, showing a significant improvement in PCR when pembrolizumab is added. And whether the tumors were PDL positive or negative in this early stage triple negative breast cancer, it did not matter. Both groups benefited from the addition of immunotherapy. It does come at a cost. Patients do struggle with this regimen with a number of non-immune related toxicities as well as immune related toxicities. So the number of events is quite high, but compared to the traditional non-containing immunotherapy regimen, roughly similar between the two arms, with the difference that the immune-related adverse events are certainly being reported in the pembro arm. Thyroid issues, adrenal issues, things that patients may end up living with for decades, even after going through curative intent. These are things that can persist, a small number of patients actually have a mortality associated with this regimen, which is, of course, terribly serious. There has been a lot of thought in, well, how can we identify who actually benefits from this kitchen sink approach? Can we de-escalate our regimens? Can we really identify patients who might be able to get away with less? And so this was a nice presentation by Joyce O'Shaughnessy that was presented in 2 San Antonios again. And the group looked at multiple different signatures, PTEN loss signature, HRD status signature, a molecular subtype signature. And really, the pembro benefit was not clearly seen in one group over the other. So again, highlighting that we need better studies, better biomarkers to be able to successfully de-escalate patients from this much more intensive Keynote 522 regimen. What about the role of adjuvant immunotherapy in triple-negative breast cancer? This has been absolutely debated. There have been a number of studies that have shown that perhaps if we only give the immunotherapy in the preoperative setting, we may not need it afterwards, and that really the biggest benefit of immunotherapy is when the tumor is in place. And so this is the Japar Nuevo study. As you can see, kind of it did not contain platinums, but contained anthracyclines as well as taxane with the immunotherapy durvalumab. And again, pretty impressive invasive disease for survival and overall survival advantage seen in a much smaller study than the Keynote 522 regimen. But this is part of the body of evidence, really questioning whether we need that adjuvant pembro portion in patients, particularly who achieve a complete pathologic response. And so this has led to a US-based cooperative group, National Cancer Institute study called the Optimized PCR study, where patients who have achieved a complete pathologic response after chemotherapy and immunotherapy are randomized to not receive any further additional pembrolizumab, so one-to-one randomization to observation alone versus continuing the adjuvant pembro portion. We've had some trouble with accrual because patients do not always agree to this type of randomization. That there have been some dropouts in the study related to the randomized nature. But what about the patients who actually have residual disease? That's approximately 40% of patients receiving the Keynote 522 regimen, even though it's our most intensive regimen, still have residual disease. And currently, based on the CREATE-X study, which is an older study conducted in Japan, patients with residual disease, the current standard is capecitabine. As you can see in the reported data from CREATE-X, there was a significant disease-free survival in patients with triple-negative breast cancer who received 8 cycles of oral capecitabine compared to observation alone. A number of other studies have looked at the benefits of adjuvant capecitabine, and there does appear to be an overall survival advantage in triple-negative breast cancer. But those of you who actively treat triple-negative breast cancer, you know that with patients who have significant residual disease, capecitabine is almost not always effective. So we absolutely need better regimens. The Olympia trial is specifically focused in patients with germline BRCA1 and 2 alterations. And I know we have a talk coming after me on this, but I did want to highlight in the context of triple-negative tumors with residual disease, olaparib given adjuvantly for 1 year has been also and is an important option associated with both disease-free survival and overall survival. So these are our current standard of care regimens for patients with residual disease after triple-negative breast cancer regimens. And this kind of summarized the extrapolation that we're doing. When CREATE-X was going on, there was no immunotherapy. When Olympia was going on, there was no immunotherapy approval. But what we're doing in real world practice is that if a patient has a germline alteration, they get olaparib plus pembro. If they do not have a germline alteration and they're not eligible for clinical trials, they get capecitabine plus pembro. So this is the common practice that we're doing in the United States based on prior extrapolated data that the combination of pembro with each agent is quite safe. A number of studies are looking at how can we improve on the experience of these patients with residual disease with the incorporation of ADCs. This includes the SASIA study, which included both triple-negative as well as hormone receptor positive high-risk disease, where patients were randomized to the TROP2 ADC sacituzumab. And we also have 2 studies looking at patients who didn't get immunotherapy originally as part of their preoperative regimen. The SWOG S1418 study essentially is looking at the question, is there a benefit to adjuvant pembro in patients with residual disease who did not otherwise get it previously? The ABREVA trial most recently resulted, and I did want to highlight the studies of this phase 3 randomized trial with the anti-PD-L1 avelumab, and it took patients with high risk early stage triple negative breast cancer, and they had two different strata. One was patients who were pre-surgery getting neoadjuvant treatment, and a smaller strata were patients with residual triple negative breast cancer who then went on to get adjuvant avelumab. And the results were kind of building on the data that when we give adjuvant immunotherapy and we haven't given it preoperatively, there was no significant benefit in disease-free survival. The benefit is strongest when we're giving these immunotherapy regimens preoperatively. However, by descriptive analysis, they did report an impact on overall survival. And I think certainly it was not the primary endpoint of the study. I do find these data sometimes helpful for those patients who perhaps we thought had clinical stage 1 triple negative breast cancer. They go to surgery and there is a surprise lymph node positivity or a higher stage than we expected. So if they're young and otherwise have good health, I think that this helps me at least justify in my mind the consideration of some type of a chemoimmune-based regimen for them. The question becomes, are there less intensive but effective neoadjuvant approaches to triple negative breast cancer beyond KEYNOTE-522? And there's a current US-based cooperative group study called the SCARLET study, based on several key studies that were conducted by Dr. Priyanka Sharma previously at the phase 2 level, taking patients with triple negative breast cancer and randomizing them to the KEYNOTE-522 regimen versus platinum-containing taxane, carboplatin plus docetaxel plus pembro. So the idea being that perhaps we may not need the anthracyclines and the added long-term toxicity associated with them. So this study is currently ongoing. There's also a number of other chemo-sparing strategies being looked at incorporating ADCs. There is a Bayesian randomized study in the US called the I-SPY study, where they are looking at a number of de-escalation approaches, including, for example, the reported Dato-DXd, which is a TROP2 ADC combined with Darva. And essentially, this is a completely chemo-free regimen. It's an ADC-based regimen. And they are showing that, particularly in tumors that are very immune-rich, we can see very high PCR rates when we're using this type of novel-based approach. So it's leading to additional hypotheses about how we can better select patients who may benefit from this newer approach. Lots of other backbones are being looked at, including additional anthracycline-sparing regimens, building on the data of sacituzumab TMT, SAC-TMT in metastatic triple-negative breast cancer. This is further moving on into the pre-op setting with Trophos 032, where again, we're kind of comparing this ADC pembro regimen and including is sequentially taxanes and platinums in combination with pembro, but plucking out the anthracyclines to see if we can have similar results to KEYNOTE-522. There's no doubt that there's synergy when ADCs are combined with immunotherapy, and this is the cell death that's triggered by the ADC actually promotes additional T cell recruitment and activation that further synergizes with the checkpoint inhibitor. So it's a good biological rationale why these studies are being done. The TROPION-04 is another example of essentially a purely ADC in combination with immunotherapy regimen. This has completed accrual in the United States, and we're awaiting results. Just because we're sparing chemotherapy does not mean that these are easy regimens, but the hope is that with these more targeted approaches, perhaps we can improve on the existing PCR rates that we're seeing with the KEYNOTE-522. I did want to highlight the NeoSTAR trial, which was a phase 2 study of sacituzumab and pembrolizumab in patients. It was a smaller study, but I think it's an important proof of principle study of essentially using ADC combined with immunotherapy. Patients had 4 cycles of this regimen. And then they had imaging, and depending on whether there was residual disease or not, they had the option for additional neoadjuvant therapy, or they had the option of going to surgery. So even though the numbers may look small, it's important to say that a third of patients actually were able to achieve a PCR with just sacituzumab and pembro. So again, if we're able to pick them and select for the patients most likely to benefit, not that sassy pembro doesn't have toxicities, but again, it's a much more elegant way of administering our latest best therapies to patients who have a very aggressive disease. There was the option of giving additional chemotherapy after sacituzumab and pertuzumab if there was suspicion of residual disease, and there were 9 PCRs after non-anthracycline taxane regimens were given. Certainly some toxicities, but really impressive responses, particularly in patients with BRCA-positive disease. So I think there's a lot of rich correlatives that will come out of this study and help guide future studies. Not a walk in the park. Patients did have toxicities, and 10% of patients did have to stop due to toxicity. Many trials are reading out and will be reading out, looking at additional targeted approaches in early stage triple negative breast cancer, looking at HER3. The HERTHENA Breast 3 study is looking at the HER3 ADC in this population. There has been some look at HER2 low and using trastuzumab deruxtecan in this population. The TALENT study was not super exciting with regard to this approach, but we'll await this the more formal results from Destiny 11 studies. And I'll wrap up with kind of additional approaches include the combination of PARP inhibitor and immunotherapy. I know we have a talk on this coming up, but I did want to put in the context of triple negative neoadjuvant approaches that we are TBCRC 056 recently read out in San Antonio, combining PARP inhibitor and immunotherapy in patients with germline BRCA or PALB2 population. And again, very impressive responses, not using a traditional chemotherapy approach. Again, highlighting that if we know what to target and if we know how to select patients for the right regimen, we do not have to give necessarily the multi-agent regimen such as KEYNOTE-522. So lots of new approaches are continuing to develop, including these bispecific antibodies that are targeting PD-1, PD-L1, and VEGF. Lots of excitement in this area. Most of the studies are right now in the metastatic triple-negative breast cancer setting, but there are studies in development looking at preoperative triple-negative breast cancer as well. Lots of new technologies looking at administration of radionuclides and peptides in triple-negative breast cancer. And then this very emerging area called induced proximity therapeutics, where essentially we're taking 2 protein targets and really targeting in a very elegant way the complex biology of triple-negative breast cancer. So in conclusion, lots of advances in the area of early stage triple negative breast cancer, but it still remains our most aggressive, most difficult to treat breast cancer. Neoadjuvant immunotherapy has been a key factor in improving outcomes, and I think the next frontier will be official approval for the incorporation of ADCs in the early stage setting, but we do need to await final results from the trials. Thank you so much, and I'll stop sharing.
Thank you very much. Thank you very much, Dr. Mariam. It was very comprehensive, updated talks. And I'm sure that it will raise many questions at the discussion part. Now we'll move to Dr. Mut'ab Al-Fihedi. Dr. Mut'ab, beyond any introduction, he's section head of medical oncology, Princess Noura Oncology Center. And he's also the president of the Saudi Oncology Society. He's in Jeddah, Saudi Arabia, and his talk will cover important topic about the CDK4/6 inhibitors, mark a new shift in the treatment of early stage hormone-boosted breast cancer. The stage is yours, Dr. Mut'ab. We'll keep the questions at the end.
Okay, thank you so much. Thank you, Prof. Ahmed, for your nice introduction. So, and before starting, I would like to thank Dr. Nafisa Abdelhafid and her team for their kind invitation. I have been tasked over the next 15 minutes to discuss with you the role of the adjuvant CDK4/6 inhibitor in the hormone receptor positive HER2 negative early breast cancer. So it is really very important that we estimate the or to do risk stratification for each patient with hormone receptor positive HER2 negative in the early setting. We know that the hormone receptor positive really is the most common, which account for approximately 70% of the cases with breast cancer. And also we know that the risk of relapse actually differ between the different subtypes. So for example, if you will look at the estrogen receptor negative, you can see an early relapse, usually between 2 to 3 years, while unfortunately the hormone receptor positive patient continue to have the high risk of relapse over the longer duration. So the way I usually remember the risk of recurrence in the hormone receptor positive disease, I usually say that in patients with node 1 to 3, usually they will develop disease relapse 1 to 3 women, so approximately 1/3. While 4 or more positive lymph nodes, you will have the disease relapse 1 and 2, which is approximately 50%. The other important point that we have to estimate the risk of disease relapse in node negative. And from previous clinical trial, it showed that those patients with high risk node negative, they usually have a similar disease relapse like the node positive disease. So let us now look at the role of the adjuvant CDK4/6 inhibitor. So we have 2 positive clinical trials, the Monarch E study and the Monarch E study, all you are aware of. So this clinical trial looked at really high-risk patient population with hormone receptor positive HER2 negative disease. And they have a maximum of 6 months from surgery to randomization and the 12 weeks of endocrine therapy following the last non-endocrine treatment. They have 2 different cohorts. The cohort 1, it usually depends on the high risk based on clinical pathological feature. So patient with 4 or more positive lymph nodes, or those patients who has 1 to 3 positive lymph nodes and at least one of the following, either grade 3 disease or tumor size more than or equal to 5 centimeters. The second cohort, which represent approximately 10% of the patient population, it actually tested the high proliferation index Ki67 in those patients with 1 to 3 positive lymph node, as well as the other features. So those patients, more than 5,000 patients, were randomized to receive abemaciclib for 2 years plus endocrine treatment with AI or tamoxifen versus endocrine treatment alone. And the primary endpoint was invasive disease free survival, and the secondary objective was overall survival. And as all are aware, so the invasive disease-free survival in this clinical trial was actually improved by approximately hazard ratio of 0.73. So we are talking approximately 26%. So the addition of abemaciclib actually reduced the risk of disease relapse as well as death by approximately 26, which is 1 in 4. And when you look at the magnitude of the invasive disease-free survival over time, you can see that the magnitude improved over time. So when you look at 84 months, you have 6.5 difference. And this actually explains the idea of the carryover effect of this medication, despite it was stopped after only 2 years. And the overall survival benefit was recently presented and actually showed that this abemaciclib with endocrine treatment after a median follow-up of 6 years resulted in improvement in the overall survival with a hazard ratio 0.84, which is approximately 15% improvement in compared to the endocrine treatment. And when we look at the absolute benefit, it's 1.8, so it's approximately 2%. The side effect of the abemaciclib is very well known. So we know that it is associated with less bone marrow suppression, despite it has bone marrow suppression within neutropenia, but also it is associated with diarrhea. And when we look at the grade 3 or more diarrhea, it is actually not of that significant. And in the clinic, we use the antidiarrheal medication to improve the and to mitigate the side effect. And one of the things which I actually started to use is the protocol of the trade dosing. So I start usually with 50 milligram for 2 weeks, and then I increase the dose to 100 milligram. And after 28 days, I reach the maximum dose, which is 150 BID. And this actually improves the take of our medication. This medication is actually associated with a rare side effect, but it is very important to pay attention on. So one is the venous thromboembolism, which was 2.5, and the pulmonary embolism was 1%. We know that the tamoxifen is associated with PTE. So, you know, like when you, I don't like to put tamoxifen and abemaciclib together, but if I have to, usually, and we will listen to the discussion, I usually add aspirin 81. This is just expert opinion after discussion with one of my colleagues in the US. And despite I discussed it with one of the hematologists, and she told me that adding aspirin will not really change much. The CDK4/6 inhibitor in general are associated with ILD 3.3, but really I notice also in the clinic that there are some medical oncologists who interpret the ILD differently with the ILD associated with TDXT. So the TDXD, we have to stop the medication once we see any radiological changes, even without any symptoms. And this is the idea of doing monitoring for ILD on TDXD. For the CDK4/6 inhibitor, if the patient is not having any symptoms, you don't need to stop the CDK4/6 inhibitor. So I noticed that they might stop it, and this is really very important. What about the other clinical trial, the NATALY study? So the NATALY trial looked at same patient population, which was high risk in the monarchy, but actually they expanded even those patients with less high risk patient population. So you can see that they added those patients with N0, and those patients with N0, they have to have a grade 2 with evidence of one of the high risk, either Ki67 more than 20 or recurrence score more than 26. Or those N0 patients, they have to have a grade 3 disease. They included any patient with any node-positive disease regardless. So those patients were randomized into 1-to-1 to receive ribociclib with non-steroidal aromatase inhibitor versus non-steroidal aromatase inhibitor. Another important difference between this and the previous clinical trial, that the tamoxifen as well as exemestane were not included in the combination of ribociclib, and this is because of the QT changes. So the primary endpoint was the invasive disease-free survival, and they have other secondary endpoint. And this is just a comparison between the monarchy and the NATALY inclusion criteria. And you can see in the NATALY, they actually expanded the patient with high risk. Remember that we mentioned that those patients with N0 who has a high clinical risk, they might be equivalent to the node-positive disease. So this is from real-world eligibility and from Tarantino, from Dana-Farber, and the investigator looked at those patients meeting the inclusion criteria for the NATALY and monarchy, and without any surprise, you can see that the NATALY actually they have double the inclusion criteria of the monarchy, so 16% versus approximately 34%. So what about the results? So the invasive disease-free survival in node negative and node positive disease, it showed that the ribociclib addition to the endocrine treatment resulted in improvement in invasive disease-free survival in both N0 and N1 and N positive disease, with a hazard ratio of 0.60 and 0.73 respectively, with an absolute benefit of approximately 5.7 and 4.4%. So this is very important slide, which really I want to show you that the disease-free survival, the distant disease-free survival. So the distant disease-free survival, I want you to see those patients who has younger age more than 40 and those patients who are elderly more than 65. And look at the hazard ratio as well as the absolute benefit. You can see that those patients younger than age 40 and those elderly patients than age 65, they actually have a hazard ratio of 0.5, both with an absolute benefit ranging between 8 to 9%. So please, we have to make sure that those patients, they receive the appropriate treatment. So what about the overall survival? So the overall survival for the NATALY trial is not yet, so we don't have mature data, but I think we are going to have the overall survival in the near future, maybe next year, and we have a clue toward the result. So when we look at the overall survival update and look at the survival status, if we will look at the median follow-up at 3 years, 44 and approximately 60 months, so 5 years, you can see that the number of death due to breast cancer is actually improved by the addition with ribociclib. So, and you can see the hazard ratio over time is improving from 0.89, 0.83, and then 0.80. So I think the overall survival benefit will be demonstrated in the next future. What about safety? So the ribociclib is associated with more suppression on the CDK4 as well as CDK6. So the hematological toxicity with bone marrow suppression is more than the abemaciclib. It is also associated with increased liver function enzymes, and there was a concern about the prolongation of the QT interval, but really after using this medication, it's not that really significant issue. So what we need is to do the ECG at the beginning every 2 weeks for 3 times, and we have to make sure that the patient must avoid drug-drug interaction with the common medication. So I can stop here, but to be honest, a very important medication which I looked in the our schedule might not be discussed. What about the role of the oral SERD in adjuvant disease? So really, this is very important clinical trial, which was presented at the last San Antonio meeting about the giredestrant, 30 milligram, and about the lidERA clinical trial. So I want you to look at the inclusion criteria. So those patients, hormone receptor positive, HER2 negative, early breast cancer, they have stage 1 to stage 3 disease. And those patients, they might have node negative, but a tumor size more than 1 centimeter with a grade 3 or Ki67 more than 20%, or high score or genomic assay, or T4N0, and also they might have node positive disease. And so it's really similar to the inclusion criteria of ribociclib in the NATALEE trial. So those patients, more than 4,000 patients, were randomized to this medication, oral SERD from Roche versus the standard of endocrine treatment. And what the invasive disease free survival, which was the primary endpoint, actually showed improvement with a hazard ratio of 0.73. And when we look at this, it's really very early with only median follow-up of 32. So just imagine, say 36, 3 years, and still you have invasive disease free survival improvement over the endocrine treatment by approximately 30%. So really, this is going to change our hormonal treatment in the future. They look at the distant relapse-free interval, and I like this point more than the first one. And again, it showed the hazard ratio 0.69. So we have a more than 31% reduction in risk of developing metastatic disease. And the good thing about this clinical trial and this agent that we know that the AI usually is associated with bony pain, muscle pains, but with this medication, it doesn't contain. So the musculoskeletal disorder, if you will look at it, it was 4.4 with the standard of care endocrine treatment, and was 1.8 only with the oral SERD. And the vasomotor and the hot flashes were similar. It is like other oral SERD, which is associated with bradycardia, but again, it is really not that problem if the patient is not having any symptoms. So this is the just a comparison between the different clinical trial at the same timeline. So if you will look at the monarchy at 2-year invasive disease-free survival and look at the lidERA, it is actually the absolute benefit 2.8 similar. If you look at the NATALY trial 3-year invasive disease-free survival, it is 2.7. So the question, with these medications in the future, what will be the role of the CDK4/6 inhibitor? We don't know. But when you look from now at this slide, it's showing that it might actually replace the CDK4/6 inhibitor. But the question, what about the addition of those medication, CDK4/6 inhibitor plus the oral SERD? We don't have safety data on this, but I'm sure that this will be tested in the future. And we have different actually clinical trial, which is testing the oral SERD. So we have the camizestrant in the Cambria 2 versus endocrine treatment. And we have, as we mentioned, the ELEGANT trial, which is looking at elacestrant in the adjuvant setting, the EMBER-4 looking at imlunestrant, and the Cambria 1, again, camizestrant. Another important clinical trial is the treat circulating tumor DNA, which is looking at the elacestrant versus endocrine treatment in those patients with high risk with ctDNA relapse. So with that, I would like to thank you all for your time.
Thank you so much, Dr. Meteb, for this elegant presentation, and really very nice that also you add the lidERA clinical trial. So now we will have the fourth presentation today by Dr. Ahmed Shehri.
Assalamu alaikum wa rahmatullahi wa barakatuh.
So go ahead, Dr. Ahmed.
Yeah, let me just share my screen just for a minute. Yes, exactly. Do you see my screen, Abu Umar?
Yes, Dr. Ahmed.
Thank you, Dr. Ahmed, and thank you to the organizing committee for giving me the chance to talk about the application of PARP inhibitors in early breast cancer, and to give me the opportunity to share my talk after two elegant speakers, Dr. Mariam, Dr. Fuhaidi, for the excellent presentations talking about the HER2 positive and the hormone receptor positive from CDK4/6 and oral SERD point of view. My role here is to talk about the PARP inhibitors in early breast cancer. That might include hormone receptor positive and triple negative breast cancer patient. As you know, that almost 10 to 15% of breast cancer patients, they have some sort of mutation. And most of these mutations are related to BRCA1, BRCA2 gene mutations, which might happen in about 5 to 10% of all breast cancer diagnosed. There are standard like biomarker tests that we request for early like breast cancer, including ER/PR receptor status, HER2, Ki-67, gene expression assay in hormone receptor positive to decide about adjuvant chemotherapy, and of course, germline BRCA mutation, specifically for women less than age of 50, any woman with triple negative breast cancer, irrespective of her age, male breast cancer patients, those who might meet the criteria for personal or family history of familial breast cancer syndromes, and of course, when we consider PARP inhibitor as adjuvant therapy, in this case, olaparib. As we know, the PARP inhibition is one, or PARP genes in general encode enzymes that might help in repair of DNA if they have single-stranded DNA breaks. So if we induce inhibition of the PARP gene and their enzymes by using PARP inhibitors like olaparib or other PARP inhibitors, this will enhance synthetic lethality in these cells, especially if they are deficient in homologous recombination repair. And this was proven in the metastatic setting, and we have two landmark studies, the Olympiad study and Embraca study, which has established the role of olaparib and talazoparib in the management of metastatic breast cancer, HER2 negative metastatic breast cancer who harbors BRCA gene mutation. So the role of PARP inhibitors have made a revolution in the management of metastatic breast cancer, but in early disease, the story is more selective and more nuanced and complicated than the metastatic setting. So talking about the PARP inhibitor in the adjuvant setting, there have been an earlier study that have included triple-negative breast cancer unselected based on the BRCA gene mutation or HER2-negative breast cancer with germline BRCA mutation. They have included in total 128 breast cancer patients. Those patients, they have been treated with neoadjuvant chemotherapy according to the standard of treatment at that time. And if this patient end up having residual node disease or residual primary tumor that's larger than 2 centimeters, they have been randomized to either cisplatin for 4 cycles or cisplatin plus rocaparib, which is another form of PARP inhibitor, for 4 cycles, followed by weekly low-dose rocaparib for 24 weeks. The 2-year disease-free survival in this clinical trial was not improved by adding PARP inhibitor, so it was a negative trial. So this was one of the initial trials trying to incorporate PARP inhibitors in the adjuvant setting in those patients with triple-negative breast cancer, unselected or BRCA gene mutant patients. Until we had the landmark study, the Olympia study, which have included HER2-negative breast cancer, germline BRCA mutant, so they mandated those patients to be BRCA mutant, and patients have been randomized, or the patients have been selected on 2 cohorts, the triple-negative breast cancer group and the hormone receptor positive group. For the triple-negative group, group to be included in this trial, they mandated for those who had neoadjuvant chemotherapy to have a residual cancer. So any patient, triple-negative post-neoadjuvant chemotherapy who has residual cancer will be a candidate. The other inclusion criteria for triple-negative breast cancer, those who went for upfront surgery and their tumor was larger than 2 centimeters or they have node-positive disease. So this is for the triple-negative breast cancer cohort. For the hormone receptor positive cohort, if the patient went for upfront surgery, they mandated that they have 4 lymph nodes positive. And if the patient was treated with neoadjuvant chemotherapy, they mandated to have residual cancer with a clinical pathological score and estrogen grade score of 3 and above. So if patients with these inclusion criteria and BRCA mutant, they will be randomized to standard adjuvant treatment plus minus olaparib, 300 milligram twice daily for a total of 1 year of treatment. So this is the clinical pathological score and estrogen and grade score. And you can see this is how they calculate it. You have to calculate the clinical stage before starting neoadjuvant treatment, pathologic stage after neoadjuvant treatment, and count the nuclear grade in hormone receptor positive disease. If the score was 3 and above, the patient would be candidate for adjuvant olaparib. These are the baseline patient characteristics, which were well balanced between the 2 groups, whether olaparib or placebo group. As a summary, the median age was 42. The pre-post menopausal ratio was 60 versus 40. And BRCA 1 or 2 mutations, 70 versus 30. So 70% were BRCA 1, 30% were BRCA 2. New adjuvant versus adjuvant approach was 50-50. And triple negative breast cancer versus hormone receptor positive were 80 versus 20. So 80% were triple negative and 20% were hormone receptor positive breast cancer patients. So this is the primary endpoint of this study, which is invasive disease-free survival. There is a clear benefit of using adjuvant olaparib in these patients. And to summarize the benefit, there was a 7.3% absolute benefit at 4 years with regard to invasive disease-free survival. And this has translated into 37% relative reduction in the risk of cancer recurrence. Likewise, the distant disease-free survival, the risk of distant metastasis, has significantly been reduced by using adjuvant olaparib in this patient population. More importantly, the overall survival also has improved by using adjuvant olaparib in this group of patients, 3.4% absolute benefit at 4 years, which translates into 32% relative reduction in the risk of death. So the 4-year overall survival was 89.8, like almost 90% for those patients who have been treated with olaparib versus 86.4% for those who didn't. If you look at the toxicity, namely grade 3 toxicity, yes, it was increased for olaparib arm, like it was reported 24.5% versus 11.3%. However, the most important kind of toxicity of interest, like acute myeloid leukemia, pneumonitis, and second primary malignancies, were not increased in the olaparib arm. If you look at the most reported toxicities using olaparib, you can see like GI toxicity, including nausea, vomiting, and bone marrow suppression like anemia, neutropenia, were the most frequently reported toxicities with olaparib. But the rate of discontinuation, the dose reduction was in 25% for those who have been treated with olaparib. Discontinuation due to adverse events was in the range of 11%. So despite the fact that we have some toxicity, however, the discontinuation rate was not significant. Based on these data, the efficacy data and safety profile, the olaparib have been approved by FDA in March 2022, so almost 4 years ago, for the use in the adjuvant setting for high-risk hormone receptor positive breast cancer and high-risk triple negative breast cancer disease. With regard to the time of using olaparib, the Olympia study have mandated that patients should finish chemotherapy 3 to 12 weeks before starting olaparib. For radiation, 2 to 12 weeks before starting olaparib. Radiation has to finish like 2 to 12 weeks before starting radiation. The olaparib can be used concurrently with endocrine therapy and concurrently with adjuvant bone modifying agent. The standard dose as per the Olympia study was 300 milligram twice daily for a total of 1 year. You can reduce the dose based on toxicity to 250 milligram twice daily. Then you can reduce it to 200 milligram twice daily. After that, if there is a major tolerance issue, the treatment has to be discontinued. Be careful for those patients who have renal impairment with creatinine clearance of 31 to 50 ml per minute. It's advised to start with 200 milligram twice daily as upfront dose in these patients. And this is where ISMO guidelines have included the adjuvant olaparib in early hormone receptor positive breast cancer, as clearly said, for those who went for upfront surgery and they have 4 and above lymph nodes positive, they are BRCA mutant, they are candidate for adjuvant olaparib. If they are BRCA wild type, they can go for one of the CDK4/6 inhibitors that Dr. Al-Fuhaidi spoke about, like abemaciclib or ribociclib. And for the triple-negative breast cancer, for those who went for new adjuvant chemotherapy plus minus pembrolizumab, if they have residual cancer and they are BRCA mutant, then olaparib is indicated in addition to the adjuvant pembrolizumab. If the patient was BRCA wild type, then Xeloda, adjuvant Xeloda, in addition to adjuvant pembrolizumab, would be the way to go in these patients. This is with regard to the official and only approved use of PARP inhibitor in early breast cancer, whether hormone receptor positive or triple negative if they are BRCA mutant. There have been several studies using PARP inhibitors in the neoadjuvant setting, and some of these, like using different kind of PARP inhibitors, whether vilaparib, olaparib, talazoparib, or niraparib. It had been used in unselected triple negative breast cancer or HER2 negative and BRCA mutant breast cancer in the neoadjuvant setting, in addition to the standard neoadjuvant chemotherapy. None of these trials have shown a significant improvement in pathologic complete response as opposed to the standard neoadjuvant chemotherapy. Furthermore, remember the PCR rate in Keynote 522 is 65% for the pembrolizumab arm, and most of these trials that I have mentioned did not beat the PCR rate that we have seen in the Keynote 522. So based on all these trials, until this point of time, there is no established rule of PARP inhibitor in the neoadjuvant setting of triple negative breast cancer or BRCA mutant HER2 negative breast cancer. So as a take-home message, the only indication of use of PARP inhibitor, specifically olaparib for 1 year, is for HER2 negative disease who are BRCA 1 or 2 mutant. And we have 2 cohorts, the triple negative breast cancer and hormone receptor positive breast cancer. For triple negative breast cancer, any patient post-neoadjuvant chemotherapy and have residual disease, or those patients who went for upfront surgery and they have a tumor size of 2 centimeters or positive axilla. For the hormone receptor positive disease, for any patient went for post-neoadjuvant chemotherapy and they have residual disease with clinical pathological score of 3 grade and above. And those patients who went for post-upfront surgery and they have 4 lymph nodes as positive axilla, they are candidate for adjuvant olaparib. Just I want to share 2 cases quickly with you. This is a young lady, premenopausal, 38-year-old, diagnosed with right breast cancer, invasive ductal carcinoma, grade 2, positive ER, positive PR, HER2 low, Ki67 was 60%, so she is luminal B. Clinical stage, she was T2 in 1 disease. She went for upfront surgery, and pathologic stage showed that she has T2, like 3 centimeter, and in2 disease, 5 out of 3 lymph nodes, and she's BRCA mutant. So this patient would be a candidate for adjuvant olaparib, given the fact that she has in2 disease and BRCA mutant and hormone receptor positive disease. The second case is, again, a 35-year-old lady, premenopausal, clinical stage T2 in 1 disease, triple negative breast cancer. So she was started on Keynote 522, followed by surgery. She was found to have residual cancer, T1B. So and she was found to be BRCA mutant. So the standard of care in this patient is to go for adjuvant olaparib in addition to the adjuvant pembrolizumab as part of the Keynote 522. With that, I would conclude my talk and thank you for your attention.
Thank you so much, Dr. Ahmed, for this presentation. We have 10 minutes for fast questions because of the time schedule. If somebody has a question, you can start. Dr. Salah.
CDK. How many biomarker good that other thing, if we find that about even you have to
Questions for whom, Dr. Salah?
Thank you so much, Doctor. And I will start with the second question. So if we have a patient who has high risk disease and candidate for CDK4/6 inhibitor, plus this patient is also having pathogenic BRCA1 or 2 mutation. So usually we start with the PARP inhibitor first. I have a few patients who really have high risk disease with extensive nodal disease. And also I put them after the BRCA1 PARP inhibitor for 1 year, I put them on the CDK4/6 inhibitor. And I think in particular was the abemaciclib for 2 years. So this is in regard to the second question. But I think, in my opinion, if you want to choose between either PARP inhibitor or CDK4/6 inhibitor, in my opinion, having a targeted treatment is better. So going with PARP inhibitor, especially that we have overall survival benefit, which is more than in the absolute benefit that even with abemaciclib in monarchE protocol. The first question, which is really very important question, is asking about, do we have a biomarker that we might utilize to minimize or mitigate the side effect of the CDK4/6 inhibitor? So unfortunately, we don't have a biomarker either to use the CDK4/6 inhibitor or to think that they might develop side effect either. What we are utilizing is the clinical pathological feature as in the inclusion criteria of both NATALEE and monarchE trial. Thank you.
Thank you so much, Dr. Mehtab. And now I have a question for Dr. Mariam. Now we have really interesting clinical trials now, DESTINY-Breast05 and 11. And this is a very common question, how we will approach the patient. We will start with neoadjuvant T-DXd or just wait to offer standard treatment, and then upon existence of residual disease, we can go for DESTINY-Breast05. And one other comment also about starting with DESTINY-11, that in the control arm, they started with anthracycline and they postponed starting the anti-HER2 treatment. Mostly all of us we start with taxanes, carbo with bertotrasto, 6 cycles rather than offering anthracycline. So what will be your approach and how you will discuss it with your patient theoretically if it was approved?
Yeah, it's a great question. I also start with the HER2 targeted therapy first. So that the whole control arm of DESTINY-11 is problematic, and the trial has faced quite a bit of criticism over the type of control and the approach that they took. In my clinic right now, the only population where I have done the DESTINY-11 regimen has been the inflammatory HER2 positive patients, which clearly are the highest risk population. Other than that, I really do prefer starting with the taxane dual HER2 targeted therapy. I am incorporating MRI imaging after 4 cycles. And I think this is where the trials are going to be headed. Kind of start with THP type regimen, get some type of a dynamic response and see where you are. If I see a lot of residual disease and it really is clear that the patient is not going to be achieving a PCR, I think I would introduce essentially the 4 cycles of TDXD in reverse order of what the trial did, essentially incorporating TDXD after THP, with the hope that giving 4 cycles of TDXD up front, I am sparing them from the 14 cycles of TDXD in the adjuvant setting. But this is constantly being debated, and I think different clinicians and different patients are going to choose differently. I'm approaching it on a case-by-case basis.
So in continuation to the same question again, usually we have a concept that using ADC after ADC is not really the most proper approach because of, internalization of the medication. So if, for example, we offer TDXD in the neoadjuvant setting and the patient didn't achieve PCR, then we offer TDM1. So, in a physiological way, or how can we, suspect or expect a response?
So I think this is where the ctDNA dynamics in research are going to become really important. I think for a patient to not achieve a complete pathologic response after 4 cycles of TDXD, particularly if they're hormone receptor negative, this is really aggressive biology. I think people have posited that on the back end, you could think about TDM. Others have said, depending on the level of risk, this may be the population where you might consider bringing back the anthracyclines. So I think what I'm hoping will happen in the next year or two is that DNA dynamics will become a critical part of this decision making. That we actually have data right now that even patients who do not achieve a complete pathologic response, if their ctDNA is negative, they may not do as worse as we think. So yes, not quite validated for clinical practice, but I think this is going to be part of the story, kind of bringing in these additional biomarkers to help us risk stratify patients better.
Dr. Mariam, I have 2 practical tumor board questions for you. Quick questions about platinum in TBH in the neoadjuvant setting for HER2 positive disease. Now, after you nicely presented the new CAR and COMPASS trial, and there is now consideration about to drop the carboplatin from the TPH versus TCPH. So in your practice in the neoadjuvant now, you still using TCPH or just TPH, or case by case?
Yeah, Cancer Center Breast Program has, by consensus, decided to drop carboplatin from all neoadjuvant regimens. I can also confirm that this is the practice in the Dana-Farber Breast Program as well. So for the most part, the US is going away from using carboplatin in any patient, no matter what their risk.
Thank you. The other question, also tumor board question about brain metastasis in HER2 positive disease. When we're going to start in HER2, which patient you exclude from brain local therapy, surgery or radiotherapy? The patient, of course, they don't like to be sent for surgery or brain radiotherapy. So which group of patients you depend only on trastuzumab deruxtecan their treatment?
What question for me? I just wanted to confirm. Yeah. So you're talking about in the metastatic setting when we see CNS disease.
CNS disease,
yes. Which patients do we focus on systemic therapy alone instead of going to local regional therapy? So I think it depends how symptomatic they are and how critical the brain lesion is. If they have edema, if it's in a location where if there was limited response, they could get into trouble. we would focus on local regional radiation therapy. But if it's a very small incidental brain lesion, I think it's perfectly okay to start with systemic therapy, knowing that particularly drugs like TDXD have tremendous CNS penetration. So it depends on the size, symptom burden, how worried am I that I need an immediate response versus I can take 3 to 6 weeks for a response.
Thank you so much. My question to Dr. Ahmed, this is more or less theoretical question. Now, in the metastatic setting, we extrapolate the need for the PARP inhibitor patient with somatic mutation and those with PALB2 also mutation. So do you think if we use the same approach, we can do this in the adjuvant setting, just keeping in mind that patient with alterations just showed some sort of good response, and choosing the adjuvant treatment based on genetic alteration, it will be the best approach?
Thank you, Dr. Ahmed. As you know, that the Olympia trial was based on the germline mutation of BRCA, not the somatic mutation. However, if for whatever reason you couldn't get into germline testing, and the only test that you have is the somatic BRCA gene mutation, in my humble opinion, I might approach this patient as a BRCA mutant, and I might use the olaparib as adjuvant treatment in these patients. I don't know if Dr. Mariam, Dr. Fuhaidi would agree with this approach. If patient has somatic gene mutation and we don't have an access to germline mutation, would you consider using adjuvant olaparib in these patients?
So, Dr. Mariam, if can you respond? Do you offer adjuvant PARP inhibitor in patient with PALB2 or somatic, or at least somatic?
So I use the PARP inhibitors quite widely in the metastatic setting for somatic alterations. I have not done it in the early stage breast cancer setting because we do have access to germline testing. So I can't comment on access issues to germline testing. I think in my practice, I've only done it for germline in the early stage. But we have really good data from the TBCRC studies and others that were just that in some CA1, 2, and PALB2 in the metastatic setting. So I can see how my colleague would extrapolate to the early stage.
Fair enough. So at the end, because of the time, I would like to thank all the speakers for their very elegant, informative presentation. And by this, we end our first day, and we just see you tomorrow, inshallah, at 9 a.m. And I would like to thank the organizing committee and Dr. Nafisa for their enormous effort just to make this presentation real. And see you tomorrow, inshallah. Thank you so much.
Thank you. Thank you, Dr. Ahmed. Thank you, Dr. Badib, for this excellent chairing for this session. I would like also to thank all the speakers. Just one reminder, the dinner will be in the next room, inshallah. Thank you all.
Assalamu alaikum wa rahmatullah. Thank you all for attending this first day of our breast cancer meeting. We hope to see you tomorrow inshallah 9 a.m. غدا 9 صباحا اليوم الثاني من المؤتمر. We'd like to inform you that this event is accredited with 21 CMEs, will be granted to those who will attend the 2 full days and signing the attendance sheet 3 times per day. Also would like to notify you that you need to be of the target audience. So please make sure to visit our app or the event page in the app so you can see if you are one of the targeted audience who will be accredited for their attendance. Thank you all. We wish you a blessed Jum'ah Mubarakah, and we hope to see you tomorrow inshallah. If you are in Riyadh and you would like to attend the event physically, you would like to come visit physically tomorrow, please send us an email. إذا كنت في الرياض وتود حضور المؤتمر غدا فعليا حضور شخصي، الرجاء ارسل لنا ايميل وسنرسل لك التفاصيل وكيفية الوصول لنا. ونرجو منكم البقاء مطلعين على جميع الأحداث والإيفنتس المؤتمرات التي سنتقوم بها مستقبلا. Thank you all for your kind attendance. Thank you all for your time, effort and everything. And we will see you tomorrow inshallah 9 a.m. Have a nice day. Assalamu alaikum wa rahmatullahi wa barakatuh.